long year since we were last all together at the Global Respiratory Summit. So it's such a pleasure to see you. If I've not had the opportunity to meet you, I'm Tanya Winders. I am the president and acting CEO of the Global Allergy Airways Patient Platform. I am going to do my very best to talk slowly today, but I need your help because you guys know me well enough to know that I get excited, I get passionate, and I'll start really going. So if I get too fast and you can't hear the translation or things are not making sense, do this, okay? Anyone at any time, sort of give me the timeout signal, and I will slow myself and try to temper my excitement and passion around all of the work that we're doing and allow the interpreters to join us. We do have our online community, so there are about 60 of us in the room today. There are another subset of our group that is online, and so again, we'll have interaction with both groups, but thank you to those of you who have chosen to make the trip to Milan, to be here with us in person. It is so great to see you all and to share this time together. Also, to those of you who have perhaps gotten up in the middle of the night or the early morning or whatever time of day it may be, to our online community. We really are glad that you're here. So, welcome. Welcome on behalf of myself. Welcome on behalf of the staff and the team. You'll have an opportunity to meet the staff if you have not already done so. I would encourage you to get to know them because they are the heart and the passion and the true energy and motor behind everything that we do at GAP. Also, welcome on behalf of your board of directors. And so I'd like to ask the board of directors to stand and sort of wave, and I'll acknowledge you. So we have Christine Warlow from Australia, Ashok Gupta from India, Migdalia Dinis from Latam, myself as the president. And then we have two board members who are not here with us today as well, representing Africa. And so again, we're so excited in Europe, and so excited to be here and to have this chance to be together. Staff-wise, I was waiting till they're sort of in the room. That's why I didn't ask them to stand, but staff, if you'll stand as well so I can recognize you. Of course, Victor Gascon-Marino, our VP of Awareness and Outreach, Spila Novak, Member Engagement, Ruth Talsinger, our Chief Scientific Officer, Kristen Willard, our brand new, announcing today, Education Consultant. So our team is growing very quickly, and we are so excited about, again, just the ways that we can support you in your everyday work as advocates in allergy, airways, diseases. So again, who are we? Where have we all come? Oh, before I forget, housekeeping. I need a confidence monitor to not forget which slides are in which order. So housekeeping. Number one, if you need translation, you can scan the QR code here and actually get live translation in French or Spanish. So we do have that service available. Also, Google Translate tends to be pretty good if you want to put on the Google Translator in audio mode for a different language. At the end of the day, we're going to ask you to return your badge, as we'll be using those again. And then please don't hesitate to ask questions throughout the day. This day is designed for you to get exactly what you need to feel more empowered and effective in the work that you do day in, day out. So a few housekeeping items there not to forget. So I mentioned the board, I mentioned the staff, I mentioned you as the attendees. I could not start today without thanking our sponsors. We have such wonderful industry partners in respiratory, and an event like today could not happen without AstraZeneca, GlaxoSmithKline, Sanofi Regeneron, and Roche as the sponsors of our Global Respiratory Summit. So let's give them a round of applause as well. All right, so I am not going to waste a lot of time because we don't have the luxury of time to waste. We have a very full day ahead of us, okay? So here you see the agenda. There is a reason why there is not times, because I don't want you watching the clock or being overly concerned about, are we 5 minutes over here or there? What I promise you, we will get to lunch promptly at 12:30. I promise you, because I had breakfast very early, so I'll be hungry as well. So I promise you we'll get to lunch promptly. And then I also promise you that we will adjourn at 4 p.m., okay? Before we have our break then to rejoin tonight for the One World dinner, which is always such a great time. And I can't wait to see everyone's costumes. Everyone brought something? Good? Okay, super fun. So, now if you lost your suitcase, you may have to improvise. This happened to me last year. And if you guys recall, I had to run across and get a Mickey Mouse t-shirt, which was the closest thing I could find to representing the United States. So again, it's going to be a great day. We're going to have some really robust discussions. Our very first topic this morning, I'm going to kick off talking about new tools to effectively engage our communities more so in 2023. Some of the most creative, innovative ways in doing patient engagement and patient advocacy. And so I'm excited to share about some new partnerships that GAP is initiating in this year. And again, that you too can utilize. Secondly, we're going to have an industry panel. So we'll have members of each of our sponsoring organizations come forth, and this is where you get to ask them the questions you want answered about working with industry. We know that things have changed dramatically over the last 3 years since the pandemic. And so we want to hear from our industry partners where their roles are, how patient engagement is evolving within their organizations, and how we can best partner and collaborate together. So that will be that session. We'll then head to lunch. After lunch, we will put you to work, okay? So rest up, listen up this morning, because this afternoon, no sitting and just taking it in. You all get to drive the strategy and the priorities for GAP for 2024. And so we'll have disease area breakouts where you'll meet by disease area and have the opportunity to talk about what is the awareness prioritization? What's the message we really want to drive in this next year? What are the educational programs that we need to support you all in? And then we'll come back and we'll do a report back in those sessions before turning to our regional breakouts. And again, we are so fortunate that we have every region of the world represented here today. That is a round of applause, right? Every region of the world is in this room. And that's why I love GAP. It's why this work truly is so inspiring for me, is because it is bringing the world together with a common cause of advancing respiratory disease, airway disease, allergic and atopic diseases. So we'll have that time of regional representation breakout and talk about how we work collaboratively across disease areas within a region of the world to advance policy and research in our space, okay? So that will be the flow of the day and the way that we'll operate our timing. And then we'll have a very special guest in our concluding session on where do we go from here. And I purposely did not put his name out because I wanted it to be a great surprise for you guys. But I'll be talking a little bit about how we take the feedback that you've given us throughout this day, turn it into our strategic plan, and the actions and key performance objectives for 2024 and moving forward. Sounds like a good plan? Sounds ambitious? Yeah, we can do it. All right, great. So, again, I've talked about the mission of GAP already in the vision of creating a world where people live better with atopic and airways diseases. What some of you may not know is where GAP sort of started and has come from in the last 15 years since its inception. So GAP was founded in 2009 by a group of patient advocates based in Vienna, Austria. It was primarily a group of Europeans who found the need to act on a more global level rather than just at the European level. And so this very, I would say, thoughtful, innovative group of individuals came together to start building a community of atopic and airways disease advocates. I actually did not get involved in GAP until 2017. It's a funny story. I'll share it over a cocktail perhaps, if you would like to know. But it was sort of by happenstance that I came to be a part of GAP because of my role in the United States leading Allergy and Asthma Network at that time. And in 2017, I was elected president of the organization. And at that time, we were about 40 organizations throughout the world. We did have global representation, but we're missing some major countries in looking at this global map as far as membership representation. And so we made a concerted effort to begin to seek you out, to ask you to come to the table, to be a part of GAP, and to come along this journey with us and seeing the vision of what we could do collectively as a community of patient advocates in this space. And so today, a very short 5-6 years later, we are 108 organizations representing all continents, all regions throughout the world, and representing, again, a host of airways and atopic disease states. And so I am so incredibly proud of the growth of GAP. So, to our newest members, part of that growth has been just in this year. We added 30 organizations this year alone. And that is really largely in part due to the efforts of Victor and Spila and the team, Migdalia, the leadership of GAP, to say there are countries we're missing the voice. We need to go and seek advocates from different parts of the world, from different countries that perhaps we've never heard from. And so these are our 30 new members just in this past calendar year. So let's give them a round of applause and welcome them to the family. With the growth of this, we have made the decision to actually create a new member portal. So there's a portion of our website that is member only. And the reason we decided to do this is because the traffic that is frequenting gap.org, G-A-A-P-P.org, not the clothing, G-A-P. I have to correct people on that quite often. But our website is drawing about 65 to 70,000 unique visitors per month, okay, from all over the world. And so we wanted to create sort of a behind-the-scenes member portal for you to access different resources and materials and things apart from the public representation and public site of gap.org. So this new member site is launching today, and we will be sending you exactly how to access, how to get on, what you'll find there, and a follow-up communication. But again, I can't say enough thanks to Victor for leading this project and getting this underway for you guys, yeah? So, now let's turn the focus. I kind of gave you a history in the last 5 or 6 years, the way that GAP has grown, but let's turn the focus to this calendar year. What's happened in 2023 and where are we going? You all know that we have 4 core mission areas at GAP: awareness, education, advocacy, and research. So when we think about how we're structuring our team and our work and our priorities, I always ask, where does this fall? Is it an awareness activity primarily? Is it an education activity, an advocacy activity, or a research activity? And that doesn't mean that it doesn't have some crossover, because they often do. A lot of our awareness also has education components and vice versa. But we always try to assign it to one of those core 4 areas. So in the awareness area, again, as our organizations have grown, as our disease states have grown, so has our activity on World Awareness Days. And so here you'll see the dates that we actually create content alongside you and then disseminate it. And then also the days that we participate in with other organizations. For example, we have World Atopic Eczema Day coming up this month, and we also have World Lung Day upcoming. And so these are things that we do in coordination with organizations like Global Skin and the Forum of International Respiratory Societies. But as you can see, there's about at least one day a month, sometimes more. There are some months that are very busy. September is one of those. May tends to be pretty busy as well. And then October and November. But these are opportunities for you as GAP members. Now, I realize that this may not be always perfectly aligned with your mission. Like, we certainly understand that. If you're a dedicated patient advocacy organization, for example, to atopic eczema, you're thinking, should I really weigh in on World Lung Day? Maybe, maybe not. That's for you to decide with your organization. But what we want to do is provide you turnkey tools and assets for social media posts, for newsletters, for engaging your community about the importance of these days and how all these diseases do connect. Because the science is evolving very rapidly to, again, reinforce what we've known is that connection between atopic and airways diseases, immunology and respiratory. And so that's why we choose the dates that we do and the awareness opportunities that we do to engage. So I mentioned that we have communication grants. These are the 3 most timely opportunities for you to come alongside us and to repost and to share. And whatever channel you choose to do that, we provide you a €200 grant to disseminate these assets and tools. And one of the things that I want to hear your feedback, and I want to encourage you to speak to our staff about, is this sufficient, okay? We sort of arbitrarily chose the 200 number based on budgets, based on what we heard from you about the time it takes, the resources it takes to amplify these tools. But I need to hear from you, because on average, we're getting good participation, but we could do better, okay? So I need you to be honest with me. If there is an opportunity where you say, you know, Tanya, €200 is just not quite enough to get us excited or involved in these kinds of things, then we need to reconsider that in our planning going forward. But these 3 opportunities are the ones that are currently at play, and again, €200 for each of those communication grants if you choose to amplify the GAP messages and resources. So World Eczema Day, World Lung Day, and World Urticaria Day all coming up within the next month, right? Hence the reason everybody's so tired with all this work that they're doing. They're doing a great job. All right, so now let's turn beyond awareness to education and advocacy. And again, we split this up by disease area because we wanted you to see the breadth and the depth of the disease areas and the education initiatives that we are focusing on at GAP. And so I'm not going to go into depth or detail of all of these. This slide is really just to sort of give you a grander picture of the connection of all of these. And then I'm going to highlight a few of them specifically. But asthma, atopic dermatitis or eczema, COPD, chronic urticaria, eosinophilic-driven disease, sometimes this is called type 2 disease, and then all the areas together. And so again, we'll highlight a few of these along the way. Some of our other projects, in 2022-2023, we actually worked alongside the EU H2023 project, put in a couple of applications. We're still seeing those through the process, and fingers crossed that we'll get an approval on one of the pending applications that's still outstanding for funding. We've continued to reinforce the message around SABA overuse, as well as systemic steroids, OCS overuse, and the importance of stewardship of those treatments, specifically in respiratory. And then we've been working alongside the World Health Organization and the GARD, which is an informal, it's sort of a partnership of different organizations throughout the world that coordinates activity with WHO in respiratory disease. And we've had the opportunity to attend the GARD conferences, to meet so many of the wonderful people. I was just speaking with Lan from Vietnam. She and I met at a GARD meeting years ago, and they have such a robust program that is one of the GARD-funded projects in advancing outpatient care for those living with asthma and COPD. So great work going on by GARD that we're very actively involved in. We also have been meeting with WHO officials in the non-communicable disease space, because currently in the NCD space at WHO, there are 2 individuals working on chronic respiratory disease. In all of WHO, we have 2. And you know how they define chronic respiratory disease? Asthma and COPD only. So there's no recognition of PH, no recognition of IPF, no recognition of alpha-1 and other conditions in the respiratory space. And so we've been working with them to determine how do we best advance lung health as a whole. And rather than looking at a single disease area like asthma or COPD, look more holistically at the person and at their lung health from the time that they are in utero, now with an RSV vaccination for pregnant women, all the way through the time that someone is elderly or in their latter years of life, and the risk factors associated each stage of life. And so what you'll see forthcoming is a draft resolution that will be moving throughout WHO and being introduced by member states and hopefully passed to elevate lung health beyond just the current limited version of 2 individuals in the NCD division at WHO. So very excited about that work. We continue to serve for the global guidelines committees for both GINA and GOLD, asthma and COPD, and have been invited to be a part of the atopic dermatitis guidelines committee and reviewing that document that's now in review, as well as the chronic urticaria updated guidelines. So again, across the board, the patient voice and GAP's representation of the patient voice at that global level in these high-level expert groups is being much more recognized than ever before. And then this type 2 evidence generation publication effort. So we conducted last year a survey across 7 different countries of 100 healthcare providers in each of the countries, 100 patients in each of the countries, living with multiple type 2 or eosinophilic-driven diseases. And what we found is that globally, unfortunately, care is not coordinated, that there is, on average, 4 providers to cover the breadth and depth of diseases that individuals are living with. And really and truly a significant burden of time and money and psychosocial impact that is underappreciated. And so we've gathered this data, and Ruth is leading an effort of author work group to actually have publication underway this year for that data. And then we'll be providing assets for you to share on how these type 2 conditions and care coordination really needs to be advanced as a patient advocacy community. Okay, so a couple of the projects I wanted to highlight. First, the COPD Empowerment Guides. This is a project that we've worked alongside Nicole Haas and her organization. And we have 2 iterations of the empowerment guides. These, again, are available in multiple languages. They take the GOLD guidelines and approaches and make them much more patient-friendly. And so this is an opportunity, again, if you're not familiar with this resource, please check it out. We're continuing to advance and do yet a phase 3 of the COPD empowerment guidelines. Ooh, yeah, okay. This is a build. Next is our biologics toolkit, our biological medications. Again, there's a lot of confusion across the world about what is a biological, why is it important, how is it relevant to our space. And so today we are launching a dedicated website content capsule on biological medications. Learn, discuss, and take action. And so again, I'm excited for you all to see this. Today is the launch date for this new resource. And I think that you'll find that it's very helpful and has the ability to, again, adapt and really help at a global level advance the understanding of biologicals and the importance in this space of atopic and airways diseases. So this is some of the content that you'll see on the site. What is a biological? How is it used? How expensive is it? How do I talk to my doctor about it? Can I even get it in my country? As you know, sometimes access barriers are there. So again, a great resource that we are very excited to share with you all. And I want to say thank you again to our sponsors on this particular project, because this is a work that we could not have done without the support of multi-funded industry partners. And so coming alongside, they had no influence. It is not promotional at all. It is not commercial in any way. But they did have the ability to help us understand what the current understanding is of biologicals, the nuances of different treatments in different therapeutic areas, and the availability across the world. And so, again, I want to thank Sanofi Regeneron, AstraZeneca, Roche for their support of this particular project. Next up is our Speak Up for COPD Coalition. This is an advocacy project that, again, if you gathered this morning for breakfast, you've already heard a bit about, and if you've been engaged with GAP for long, you know about. But a very important coalition of patient organizations, professional societies, and industry partners coming alongside to say, no more will we allow the third leading cause of morbidity and mortality across the globe to be neglected. And so this is a very important effort that we launched in 2021 and has continued throughout 2023 and 2024 with the mission to amplify the voices of the COPD community and to really establish COPD as a public health crisis and priority. I was saying this morning, the world has stood still over the last 3 years in paying attention to lung health, all because of COVID, right? And yet, did you know that every year more people die of COPD than died of COVID in the first year, in the heightened period of the pandemic? Every year we're losing that number due to COPD. And yet, most people don't even know what the term stands for. And so we've gathered some data. We'll be sharing this data and amplifying it through the coalition and through your efforts to really speak up and understand what do we need to do to change this current condition of deprioritization of COPD. And you can see the great organizations that are involved here. So appreciative of the COPD Foundation and their leadership, of other professional societies, the pharmacist, the International Federation on Aging. This really does cut across, again, disease area. And it's been such a nice collaborative to see respiratory nurses, professional societies of pulmonologists and primary care respiratory providers come alongside us and say, let's do something about this. We can do more together than we could ever do independent. And so here you'll see the timeline of the work that was done in 2021, 2022, and as we've moved into the new year of 2023. And then this slide actually talks specifically in the last sort of 5-6 months, some of the efforts that we've had in this coalition. So we finalized the governance process, because when you bring all these different stakeholders together, there needs to be a formal way that we're going to make decisions and hold one another accountable for showing up. We've launched 2 new coalition projects that, again, you'll hear much more about. Our Ipsos Mori polling data, which is policymaker polling, and how they actually don't recognize what COPD is, don't prioritize it, don't resource it, and how we can use that data. And then we've added new members, as I said, the pharmacist, having this multidisciplinary team approach to addressing COPD really has been at the top of our priority of the building out the coalition. We have an executed memo of understanding for all the various partners that are involved, and we've had some publications in policymaker journals and articles like Politico with that data that I shared. So what's on tap for the remainder of this year for Speak Up for COPD? You can see here our timeline of September moving forward. We have, at this Congress, several of our industry partners have actually got Speak Up for COPD Coalition resources and materials and, a presence, which is so amazing because, unfortunately, there is no patient village at this ERS. There is no real presence beyond the European Lung Foundation for opportunities for us to speak to the providers, the 25,000 lung doctors that are here. And so, again, we're so grateful for the way that our industry partners have helped us to amplify the Speak Up messaging across the provider community here at this Congress and more. We have a policy workshop that's coming in October 5th and 6th. So if you're in the COPD space and don't know about this, please reach out. We'll be happy to share more about it. But it's how do we actually engage policymakers? How do we get policymakers' feedback on what's going to matter to them? And how we can really work alongside them to change the landscape. And then you'll see, again, a lot of activities around World COPD Day, the Gold Conference. Again, I can't say enough thanks to the team at COPD Foundation for working alongside us to ensure that GAP has a presence at the Gold Conference. And Jean Wright, the CEO of COPD Foundation, is here. So again, just such a robust community in the COPD space. As many of you witnessed this morning, I think we're a very passionate group that's ready to put all the resources and the force and the aim in addressing this public health really crisis. I don't know any other way to describe it. So moving on from awareness, education, advocacy to research. Research is an area, again, where unfortunately the patient voice has not always been prominent, right? For so long, I remember about 10 years ago, someone said to me, well, you're not published. And I said, well, who's gonna let me publish? I mean, I'm just a patient. I'm just a patient advocate. And it really was met with a lot of hesitancy to get publications in peer-reviewed medical journals. So 6 years ago, we made a decision and a concerted effort that we're going to go out, we're going to really push our industry partners, we're gonna push our medical societies, the expert communities, the centers of excellence to say, nothing for us without us, right? We need to be involved in peer-reviewed medical publications, in medical journals. And so since that time, 70 publications from our community where we are authors. And that's individuals like Mary Jo Strobel, myself, others around this room who again, Maryland, I was looking, where are my Marylands? Who say, again, we deserve a spot at this table to craft the message that's coming out of clinical research and to ensure that there is that patient voice, that patient centricity, and that the data that is developed is then communicated back to the community that it was designed for, right? And so we've worked to design clinical trials, we've worked to recruit in clinical trials, we've worked to disseminate data of clinical trials, and we were in a meeting yesterday for a study with Roche that we were so integral in every step of the process of making sure that this is a patient-centered trial. And again, the difference that 5 or 10 years makes in this space is remarkable. So excited about these publications, and you can check them out. We do have, I think, 4 more publications that are in the review process and should be approved in publication by the end of the year. So again, if you're looking for resources, things like the patient charters, quality standards, patient-reported outcomes, if you want to be involved in this type of work, if this is something that gets you excited and you want to say, I'm willing to devote hours on end of reviewing clinical papers and data and be part of author work groups, please let us know, because those opportunities do continue to present themselves. So that's the 4 mission areas. But the truth is we can't do any of this work alone. It's not GAP independently. It's you as our community, as our member organizations. It's in coalition with the professional societies like the International Respiratory Coalition, which is led by ERS, that we advance this kind of work. And here at ERS 2023, I have to tell you, again, a milestone, monumental feat is that we have 3 symposiums and 2 poster presentations as GAP at this Congress. And one of those is the IRC. And so again, very excited about the work that's happening here. Now, what I'll tell you about the IRC, because I've heard from some of you the concerns, and quite honestly, I understand and agree. Currently, the IRC is solely focused on European pilot projects in this year of 2023. The aim is to then take those learnings and advance that into international projects in 2024 and beyond. So I know it's been fairly limited in scope thus far for those of you who've checked out the IRC, but trust me, we're gonna keep pushing to make sure that it truly is international and engaging the rest of the world. Let's see. So as I said, with all of this growth, it has meant also the growth of our board, who you see here, our 2 new members from the Asthma Relief Campaign Project of Nigeria, and we have a representative with us. I'm looking, where am I missing him? Ah, yes, I was like, where are you? So we have a representative here from that organization as well. And then from Vietnam, again, our vice treasurer from the Society of Asthma, Allergy, and Immunology. And one of the things that we've realized, of course, over GAP's existence of the last 15 years, is that patient advocacy looks very different in different regions of the world. And what works in North America may not work in Latin America. What works in Europe, even in perhaps Western Europe, may not work in Eastern Europe. And so that is why we are devoted to developing these regional alliances that are more focused efforts on how we can work across therapeutic areas in the different regions of the world. And so we've introduced 2 regional alliances in 2023. The first is LATAM, and I'm looking at Medalia Dennis, who's leading our efforts there. And we have such a great representation from Latin America here today. And then our second is actually Eastern Europe, led by Spila Novak. And so, again, those are our first 2 regional alliances. When we have that proof of concept, when we see how well this works, when we get the key learnings from you guys as those first 2 groups, then we're going to expand, and we'll have an Asia Pacific regional alliance. We'll have a North America regional alliance, as well as other African and other regions of the world, okay? So that is what is coming. I've already said about the staff updates and recognized the group here, and again, they make me look good. They make my job easy. And so as you get an opportunity throughout this day, please express your gratitude to the full team. I don't know about that. Some days. All right, so I want to pause there because that is a good stopping point to say that's who we are, that's what we've done in this year, and kind of since we were last together, an update for the groups. I'll pause any questions, comments, anything coming from our online community that perhaps I could clarify. Any? Slow down? Good. Tell me. Yeah, I'm going to slow down. And we have roaming mics if anyone needs it. No questions? Okay, don't be shy. This is supposed to be interactive here. All right, so now let's turn towards new tools and how we can effectively engage in 2023. Before we go into this, though, I want to stop for a minute because I'm going to be a little vulnerable and transparent with you guys that this has been a hard year for me. A lot of change, a lot of transition in my life, both personally and professionally. And so it's been a challenging time. And someone said to me the other day, "How are you?" And I thought, you guys know. I said, I haven't even stopped to really think about how am I? And then they said, "How are you honestly?" Honest answers only. Okay? So I want us to stop for just a minute and think about how are you? Right? Honestly, here 8-9 months into 2023, how are you? For some of us, it may be a 10. It is our rock star year. The stars have aligned and life is great. You guys, most of you know, I'm the mother of 5 young adults. My oldest daughter married this year. So this is her rock star year. I mean, it is, everything's about her. The world is at the top of her game, right? Others of us may have had really challenging years. We may have had health issues. We may have had job issues, challenges. So it's maybe like a 2 or 3 on the scale of 1 to 10, right? And then some of us were just sort of in the middle, if we're honest. We're just kind of coasting. And I think that it's always good to take stock in different moments of time and say, how are you? How are you honestly? And the reason I say this at this particular point is because I'm going to be throwing out a lot of really new, creative, innovative tools. And you may be saying, Tanya, we're just barely getting by. I don't know how we're going to do any of this. And that's okay. We are not here to say everyone has to do this the same. We are not here to say that everyone should be doing any of these things, much less all of them. We're here to say these are ways that we found to be successful in patient engagement and patient advocacy. And we want to come alongside you in whatever stage you're in to do that better, to just step one step forward, one step up from where we're at today, okay? So I wanted to just kind of ground in that because it is a bold, brave new world when it comes to new tools for patient engagement. It has changed dramatically. What worked even 3 years ago, pre-pandemic, may not work today because the world is at a much faster pace, the noise level is much higher, and how do you break through that? How do you get your message to the community that you want to support and serve? And so, again, in this bold, brave new world, I'm going to share a few of the things that I think will be beneficial to you. So the first is a partnership that GAP is entering into with YouTube Health. How many people on the planet have one of these? Does anyone know? How many? So there's about 7 billion people on the planet. Over 4 billion have one of these. 4 billion people with cell phones, small computers carrying around all the time, right? And YouTube is the fastest growing social platform on the web. Video and video content, again, is the most preferred way that people choose to get their information. So no longer is it go look up on the internet how to change a flat tire or, bake a whatever. You go to YouTube and there's a video. I mean, I get these 2-minute short reels in my feed all day, every day. And it's amazing how they know exactly what I'm interested in, right? Big Brother is watching when it comes to these things. So we're going to talk about some of those tools, but this particular one is very exciting. And I know that for each of your organizations, you have health professionals that are associated, that do medical review, that create content. And so YouTube Health is the platform that we are going to work alongside as credible health sources to really release the next generation of content. And we need your help to do that, okay? So let's learn a little bit about YouTube Health.
YouTube has over 100 billion hours of incredible content being watched every day, and over 2 billion logged in viewers visiting every month.
This is where the world comes for video.
So YouTube wants to harness this opportunity to be the primary resource for authoritative health information on the web.
Every day, people use YouTube to ask questions and explore topics related to their health.
and it's vital that we ensure that they can find information from authoritative sources.
That's why a group of health professionals like me are here on behalf of YouTube to give you the facts about our new program from YouTube Health.
The mission of YouTube Health is to empower people to live their healthiest lives, helping them make informed decisions through knowledge, belonging, and inspiration, right here on YouTube.
Over the years, we've developed a framework to deliver reliable health information to viewers by raising up content from authoritative sources in search results and recommendations.
YouTube developed principles with the help of an expert panel convened by the National Academy of Medicine, the World Health Organization, and the Council of Medical Specialty Societies to better identify authoritative health creators for viewers.
So what were the results, and how can you take advantage of them?
Well, under these principles, YouTube is launching 2 amazing key features to amplify creators and define what it means to be a credible source of health on social media.
The first key feature is channel context labels, which help users identify channels from certain categories of licensed healthcare professionals.
Eligible and verified health professionals and organizations that apply may receive a blue information panel beneath their videos so that viewers have visibility that the content is from a licensed authoritative source.
The second key feature is expansion of the From Health Sources shelves. This shelf in the search results currently highlights videos from academic medical journals, hospitals, and government health authorities.
And as part of this new program, creators and companies that apply and meet the eligibility criteria will also be eligible to show up in the shelf.
For creators out there with health-focused YouTube channels like me, this is great news.
YouTube is launching a program where you can apply to have access to these new health features, and they're doing it with the help of experts who helped create guidelines on how authoritative health content sources are defined.
So what are you waiting for? Are you ready to get started and learn if you're eligible for these new user-facing health features?
First, find and fill out the application at health.youtube.
A part of the application will be an attestation where you state the information you post is created in best efforts to be science-based, objective, transparent and accountable, inclusive and equitable.
Once you've filled out the form, YouTube will send it off on your behalf to one of their third-party partners to verify your identity and licensure.
This step confirms that you are in fact a licensed health professional representing either your own health channel or a health channel for which you have oversight and review of the videos posted on YouTube.
Currently, this program is open to licensed medical doctors, licensed nurses, and a set of licensed mental health professionals.
Note that for your application to be accepted, you must be licensed in one of these health professions in the country in which you're applying to be an authoritative source.
When YouTube gets the green light from the third party that your license is valid, the team at YouTube does another review of your existing content to ensure that your channel adheres to their policies and terms.
This part of the review could take 1 to 2 months, and once the internal check is complete, YouTube will get back to you with a decision.
Once approved, you are officially eligible for these features on YouTube.
Whether you have busted medical myths, explained disease process, shown ways to cope with anxiety, or help others better understand fertility,
It's creators like you on YouTube who are helping people become more informed, engaged, and empowered about their health.
We are very excited for you to join us and our community of diverse voices,
Bringing reliable, helpful health information to the world at health.youtube.
So again, I am incredibly excited to announce that Dr. Jamie Rutland is one of the medical directors licensed in the US who is working alongside of us to create this content. And YouTube actually came to Gap and said, we see the presence that you have, we know the disease states that you cover. Would your organizations be willing, as the first global network of patient advocates, to be credible sources on the YouTube Health platform? So I am so excited about this. So now you say, okay, great, Tanya, but how do we create those beautiful videos? Because I'm not a videographer, and I don't have thousands of dollars to hire a videographer and to do this. And so that is the introduction of the second tool that I have highlighted today, and it is a platform called Storyvine. And so Storyvine is a platform where actually it creates video agility and that ability to create and share high quality videos anywhere, anytime, by anyone using this, okay? And so how is this different? You know, again, the two options of like the homegrown user-generated content that a lot of us do today versus the very polished professional videos that a lot of our industry partners perform and put together. And so how do we marry that in between? And it's through this platform called Storyvine that Gap has purchased a platform and a relationship where we're going to do multiple projects in different disease areas to make sure you get to build the content you want, you need, in your native language for your community. So how does it work? There's actually a very well-defined process where they provide templates, and then they send you the exact example of questions to answer, and they tell you how to line up the camera, what to do on your background, and then in an automated, amazing, I can't even explain it. It goes into a cloud, and within 5 minutes, you have a professionally edited video. It is incredible, guys. I am so excited about this platform. It's so cool. So that you kind of get a feel for it and how it works, this is a project that was done in rheumatoid arthritis. And so you see it tells you first to take a picture. You've got this virtual director who walks you through the process. It tells you to introduce yourself and exactly, how to frame that, what you're most passionate about, why did you seek out help, why are patient advocacy organizations important, and then the greatest source of support that you've had. And so each of these videos will have that kind of framework and narrative, very tight, 3 to 5 questions that everyone's creating similar content across the globe, but tailored in their language for their community. And again, it's just fantastic. And in no time, literally, when this goes out to you, within 5 minutes of you recording each little snippet, it goes up into the cloud and produces a beautifully edited professional video that I'm going to show you now. So auto magic editing is what it's called. Don't you love that term? Auto magic. Auto magic. Okay, here we go.
Hi, my name is Ellen. I'm from Bellevue, Washington, and I was diagnosed with rheumatoid arthritis about 22 years ago. I'm most passionate in my life about my family. I have a 20-year-old daughter who has just been a joy for me. We also are very involved in the equestrian community, and I play tennis, run, and like to exercise a lot. I sought medical help 22 years ago because I was finding when I arose in the morning, my hands were very stiff. I could not really move my hands or my fingers until I took a shower, and about 20 minutes or 30 minutes went by. I was unable to pick up a coffee cup, and it was just getting progressively worse, and I sought medical treatment. My greatest source of support living with rheumatoid arthritis has been speaking with other people about what they've gone through, reading a lot about the effects of rheumatoid arthritis, and also I've had wonderful physicians in medical treatment, which has helped keep me on track to do all that I could to avoid the long-term effects of, degenerative joints and inflammation and pain. The advice that I'd give to somebody just diagnosed with rheumatoid arthritis is really to seek out other people who are experiencing rheumatoid arthritis. When I was originally diagnosed, I spoke to my doctor, who gave me very good medical advice, but I don't think that I received the kind of support that would have been really helpful at that time in terms of what to expect from someone who was dealing with the disease. I thought it was important to share my story about rheumatoid arthritis because I gained so much in speaking with other people to understand the progression of the disease, things that they have done to make living with the disease more manageable, and just, kind of those tips and kind of, someone just to share with and understand and maybe support somebody else in their dealing with the disease.
So on something like this, you'll actually be able to put your logo, your contact information. Again, if you have a primary language that you wish for it to be recorded in, all of that is up to you. So all of the templates will be tailored to your needs and your organization. If you want to do this within your community, there's a lot of different applications. Perhaps you're going to your government and asking for a policy change. Everyone could do the same sort of framework and film a dozen videos in a day. Perhaps you are doing a fundraiser and you want to get testimonials from your community about the way that your organization can be supported. Again, there's so many applications for this tool. And as we go into this afternoon, I want you to really think about how do we creatively use video to engage more effectively. So next up is artificial intelligence. Can someone define artificial intelligence for me? What do you think of when I say artificial intelligence? Anybody? Huh? Yeah? Will you take this? Yeah, because of the online. So yeah.
I mean, it's something that should help us to make easier, quicker, and more accurate decision in one way, and in another way, very, very dangerous thing when we talk about health. That's my personal opinion. When we talk about machine learning, because I believe that this is good for already very experienced physicians, but we have problems when it comes to the young physicians and doctors who didn't see that much patients, and then it can be, the sword with two blades.
Yeah, such a great explanation. Thank you. Anybody want to add to your thoughts on artificial intelligence, AI?
So it's really simplifying a lot of data and using algorithm to integrate a lot of information that is complex into a decision-making tool. So as you said, it's really tough to make decisions. There's a lot of information out there. It's really distilling all that information into a simple decision-making tool.
Yes, yes. Magdalia, would you add?
Yeah, thank you. I think for a patient organization, it's a very good tool because we can create program in order to empower our patient community, and we can make many decisions with support with artificial intelligence.
Yes. Yeah, so this is a field that it's just exploded in 2023. Currently, there, and again, so many applications. So artificial intelligence is being used by the Food and Drug Administration in the United States. There are 500 registered applications for AI health tools under review today. There are clinical decision systems that are being developed by taking massive degrees of data, putting it through this machine learning and saying, if a patient demonstrates A plus B plus C, the likely course of action should be XYZ. Never before have we had the opportunity with so much information, so much data to make truly evidence-based, informed decisions. And yet I hear your concern. I share your concern. In the wrong hands, in the wrong way, this feels icky to me a bit, right? And so I want us to think about different tools that are coming in AI, specifically in our space. And I've got a compendium of several to share, but I'm only going to highlight one today. But there are skin check apps. So in atopic dermatitis, you can now use this to point to a lesion or a breakout, and it will tell you what it is based off of AI. Now think about the application of this for low to middle income countries, for rural health, for people who can't wait 6 months to see a dermatologist. Think about this in the space of respiratory, where in some parts of the world, respirologists, pulmonologists don't even exist. Or maybe where there's 1 per 1 million, right? And so there's so many different applications to AI, and it's happening and adapting so quickly. And this is the thing about AI, that machine learning, the more information it gets, the more accurate it gets in those models, in those algorithms, in those clinical decisions. And so rather than us as a patient advocacy community being fearful of this, which I think is a pretty natural place that we could be, I want us to explore it. I want us to really think about, and I need your feedback to say, where is it appropriate for GAP to be involved in this kind of thing, right? Because again, it may not be right today, but who knows what 5 or 10 years is gonna hold, or 2 or 3 in the case of how fast this particular field is advancing. So I wanna highlight one particular AI tool in asthma that I have become aware of that I wanted to, it kind of brings this whole thing of AI in our space to life.
COPD and asthma are major health issues globally. In Denmark alone, we have more than 800,000 patients. There are huge societal costs associated with suboptimal management of COPD and asthma at home settings. The costs associated with lung diseases in Denmark is a staggering 20 billion Danish krone annually. Briota is on a global mission to improve lung health of 1 million patients. Our innovative AI-first solution, SIA, is proprietary, patented, and battlefield tested in India. It has already helped more than 40,000 patients in the COVID-19 pandemic. SIA platform consists of 3 elements, which in combination provide a unique and superior disease control. Home monitoring kit for patients, clinical decision support system software, and telehealth coordinator support. The clinical decision support system software comes with personalized and holistic action plans, actionable insights from adherence data, and recommendations on prioritized care. SIA platform is hardware agnostic. Doctors and patients can choose any hardware they want for home monitoring. It works on the principles of no-contact AI. We use AI to help doctors and nurses make efficient and right decisions at the right time, even when they are not physically present with the patient. SIA helps reduce flare-ups and potentially reduces rehospitalization, need of intensive care, and duration of hospital stay. Ultimately, SIA helps improve quality of life for asthma and COPD patients and helps them breathe easy.
So again, that's just one example of where they're using remote monitoring tools and the data from that to do better clinical decision making in asthma and COPD in India and Denmark. And so if you're interested in this space, if you want to explore perhaps together opportunities within your own country or your own region to do these types of projects, then again, we're here and want to go along that journey with you. Next up is Google Health, and again, this is Google's way of advancing health artificial intelligence specifically. And so I'll allow Joseph to give the full explanation of Google Health and their AI efforts.
Hello everyone, I'm Yossi, and I lead impact-driven research at Google. For over 16 years, I've been developing advanced technologies and AI solutions, as well as products that touch billions of people. AI is advancing at an unprecedented pace, It is a revolutionary technology that I believe will benefit almost every sector of society. And nowhere is the opportunity to help people around the world greater than in healthcare, where AI can have a transformative impact. Moving from research to clinical reality often takes years. And now we're seeing the impact of our breakthrough research, which is empowering healthcare professionals across medical fields, such as tuberculosis, various cancers, and eye diseases. Take, for example, diabetic retinopathy, which can cause blindness in diabetic patients if left untreated. Early diagnosis is vital. A seminal paper from our Health AI team, published in 2016, led to ARDA. ARDA stands for Automated Retinal Disease Assessment and is a screening tool to detect diabetic retinopathy. I've seen firsthand the impact of our research into diagnostics once it is ready for use in the clinic. When I was in Thailand last December, it was really inspiring to see ARDA in action and to speak to the healthcare workers using it. They are now able to screen 40 patients in just an hour. A patient sits in front of an AI-powered camera and receives the results in less than 2 minutes. The use of AI is helping prevent blindness with over 200,000 patients already screened worldwide. Today, you'll hear about even more ways we're using AI to help in healthcare.
So, we are in conversations with Google Health around their lung cancer detection program. So you saw that's one of the applications here, lung cancer screening, lung cancer detection. Oftentimes when there are lung cancer screenings, we tell people, congratulations, you don't have lung cancer. But we don't tell them why they have breathlessness. We don't tell them what it may be, asthma, COPD, pulmonary hypertension, something else. And so we are partnering with Google Health to build in validated questionnaires into that lung cancer screening to then build upon that and better, earlier identify patients living with respiratory conditions like asthma, COPD, PH, and others. So these tools, I just want you guys to know, the data that comes from this, we will have access to that. We will be that premier partner that's kind of on the cutting edge of, again, recognizing opportunities to go where people are living in their communities and help them along their patient journey to get the appropriate diagnosis and care and treatment that is so desperately needed. So the final tool that I want to highlight is Amazon Health Clinic. And this is a North America tool today, but we've been in conversations with Amazon Health about how this will build across the globe in very near future. So Amazon, I'm sure you all are familiar with. At any point in time, you can ring up Amazon and get something delivered to your home, whether it be your groceries, whether it be your, sporting equipment, I mean, you name it. And during the pandemic, the explosion of use of Amazon really is pretty remarkable, right? But this area of health has been an interest of Jeff Bezos and the team at Amazon for quite some time. And so they have this year launched Amazon Health, and I'm going to allow them to introduce it, and then I'll talk about the application in our space.
Meet Amazon Clinic, a virtual care service that helps treat common conditions like pink eye, erectile dysfunction, sinus infections, and more. First, choose a condition. Depending on your location, you can either message with a clinician or have a video visit. Next, choose your telehealth care provider. No insurance needed, no bills later. Answer some questions about your health and how you're feeling, and a clinician will review your information. If you chose a video visit, you'll be notified when it's time to chat with a clinician. During your visit, you'll discuss your symptoms and medical history. After your visit, your clinician will send a personalized treatment plan and any necessary prescriptions to any pharmacy you like, including Amazon Pharmacy, which will deliver to your door. Message your clinician for up to 14 days after your visit at no extra cost. Amazon Clinic. Get back to being you.
Pretty cool, huh? So within a few minutes, For an established condition like seasonal allergies or asthma, you can click, have either a text message visit or a telehealth video visit for between $30 and $70 US. No insurance, no, referral process, anything like that. And then, again, you can get your refill medications, you can get the care that you need through this service. Now, again, this is not for everyone. It's not to replace your specialist care. We're not suggesting that people are replaceable by Amazon. Please don't misread me. But we are in discussions about how to use this telehealth platform and the data that's generated from this platform to better engage and to get individuals perhaps living with symptoms and not fully connected to a healthcare system or provider, connected to a patient advocacy organization. And so that's where this is going. And again, if you look at the disease areas that Amazon Health is currently covering, there are about 3 or 4 that are already in our space. And so that conversation is ongoing about how that builds out and how we support the community through these innovative, creative digital health tools. I think we have a question. Yeah?
Yeah, hello. So I just want to take 1 minute first to say hello to everyone. I didn't have the chance to welcome you all because, logistics like minutes, but thank you for coming and welcome, and we get to talk later, I guess. Just before the question, one reminder for the people online and in person, we have live translation in French and Spanish, so you can join from the Zoom. You can register here in the badge and then get access to the Zoom if you want to hear the live translation. And Vildana wants to share a publication from Dr. Turkalj about machine learning.
Sorry. I just wanted to say how thankful I am to be part of this group and Southeastern Alliance as well within GAP, because while you were talking, I just wanted to share with you that there is a Professor Turkalj sitting with us, and she's a lead of the research predicting treatment outcomes using explainable machine learning in children with asthma, and you can find it on PubMed. So we are really so happy that we can interact and have these kind of experts within GAP. So that's the thing I just wanted to share. I think
we do have, I didn't want to embarrass, I knew she would probably be embarrassed, but we do have experts sitting around this room who are doing this work, and you will have the opportunity at the ERS throughout the Congress to engage and have those upfront discussions with them around the use of this technology. Did you want to say anything? Sorry. We didn't talk before, so I didn't want to embarrass her.
About this, so I think
yeah?
Actually, I wouldn't like to disturb your fascinating explanation about artificial intelligent machine learning.
Yes.
But interesting for me, I'm actually a physician, but maybe next day I will be also the patient, and also I have kids with asthma, and I'm personally involved in the treatment of patients with allergic diseases and asthma as well. And because of that is my personal interest to join your organization. And also I'm a teacher, I'm a professor in medical school, and I teach my students about artificial intelligence and also machine learning. And also I published 2 papers about how we predict the outcome in patients with asthma according to the different symptoms and other signs which are important for in decision-making process.
Yes.
And because of that, we would like to share our experience with some other researcher, and because of that, we published that results in PubMed.
Yeah. Thank you so much, and thank you for the work that you're doing and for your perspective as a healthcare provider, an academic researcher who's dedicated their life to this space, but never forgetting that we're only one day away from being patients ourselves, right? And we're people who also, by the way, also live with these conditions. And so really thank you for sharing that and for highlighting the work. I mean, we'll maybe send it around as part of the post communication, a link to that article. I think that would be great, Vildana. Thank you for pointing it out. So again, Amazon Health, lots of applications and opportunities to leverage telehealth alongside these very easy to access digital health tools. Now, I lied because there is actually one more tool that I almost forgot about, and that is chatbots. And it sort of goes along the line of some of what we were talking about with the artificial intelligence, but slightly different. So chatbots, anybody familiar have used chatbots? Yeah, I see. Yes. Okay, great. And so again, you know that this is an automated way to take narrative and to have a conversation to gather data around a patient's journey and their lived experience, and then really better understand that journey or lived experience. And so I wanted to share one particular chatbot called KBot that is focused on asthma with you all today.
Hi.
Hi there, welcome. I am KBot, your personalized asthma care bot. Let's talk about how you have felt today.
Okay.
You have already reported cough as your current symptom. Did you get any symptoms other than that during the day?
No.
Moving on with your medication. You were prescribed to take Flovent daily. Did you take it today?
No.
That's
None of
not
our
good.
patients.
You should not skip your Flovent. Please consider taking it regularly like your doctor said. It might not help you right away, but it helps you maintain your asthma over the long run. Now, let's measure your lung function using the peak flow meter provided along with your K-Health kit. It looks something like this. Keep blowing on it until it beeps. Please provide me the PEF value when you are done.
220.
Your PEF reading shows that your lung function is good.
What are common asthma triggers?
Asthma triggers are the factors in your surrounding exposure to which may trigger your asthma symptoms. There are different types of triggers based on how they affect your asthma. Some of them are allergens, air irritants, weather, exercise, and strong emotions.
How to use an inhaler?
Got it. Let me find something. Here is a video that tells how to use your meter dose inhaler. Click on the video to play it.
Tell me about my asthma.
Today is your 7th day with me, and you have reported symptoms only on 4 random days with no exacerbation. Also, your medical compliance looks good with a compliance score of 89%. All of your PEF values are better than 80% of your best. This shows that your asthma is well controlled. Keep following your regular care plan. I have generated a chart on you that show your symptoms and inhaler use per day. Have a look.
So again, these tools aren't necessarily perfect. I'm not saying that they, again, would replace a human being. However, I think they are advancing very rapidly, and that the data collected from these types of tools will be just so valuable to the work that we are doing in helping to understand how we can support patients in their journey to use their inhalers correctly, to take their medications as prescribed, to track their symptoms, to have more effective shared decision-making discussions with their physicians. This is the kind of work that these innovative, creative tools can support you and your work as patient advocates. And so I hope that this has sparked your creative thoughts around how you will engage with your community moving forward. And what I'll tell you is that, we are committed to, again, not saying that this is for everyone, that it is applicable in every country, but if you want to explore opportunities or partnerships in your part of the world, in your country, then we're here to help you do that, utilizing these creative, innovative tools. I wanted to just highlight one final really great piece of work from one of our members, the Austrian Lung Union, and I'm looking, do I see Gundula? No? Anyone from Austrian Lung? No? Okay. So Gundula Kobelmüller is the representative from Austrian Lung Union. To Gap, Otto Sprenger, our founder, one of our founders and former treasurer, was the managing director there for quite some time. And just last night, they released a documentary called a Severe Asthma short film that you can see here. They had a premiere event last night that I think was hoping to draw about 300 people. And again, just a great work of creative, innovative, event-focused ways that we can get our message out there. Okay, so that is the end of that session. I'll open it up to any questions for a couple of minutes, and then we're going to take a quick break before we go into our industry panel. Any questions about the innovative tools and the partnerships that I have outlined? Yes, Susanna. And before anyone asks, I know that this would come up around HIPAA compliance, GDPR compliance. All of these that are operating in the respective countries are, in fact, HIPAA compliant, GDPR compliant, and are going through those stages to make sure that we do this in an ethical, transparent fashion. Yes?
Hello, everybody. I'm Susanna from EFA, European Federation of Allergy and Airways Diseases, Patients Associations, and I really want to congratulate you about taking steps in these partnerships. And I'm wondering how we could, because a lot of our membership is, cross-cutting. Many European groups are both members of EFA and GAP. So how might we, leverage this together somehow? And what we would like to do as IFA next year is to have a conference dedicated to AI in allergy, asthma, and COPD. It's just an embryo of an idea, but it might be nice to try to collaborate on that.
Yes.
But we also think that there are great opportunities in the AI. But like you said, patient groups, we have to be there and not to wait and just warn patients because we ourselves don't know how these things are going. Yes. So there are opportunities, but also threats.
Yes,
like you said
I agree.
in this chat box, you could, when you are a patient organization involved, you can hear the nuances that are not there, which are critical for your individual asthma thing, so that you don't get the wrong message from this. So we need to be able to read those and bring those nuances in.
Agree. What, again, the opportunities that I see, we would love to support those types of meetings or conferences about how AI is being used in our space alongside you in your countries or regions. If you want to gather academic researchers and providers that are interested in this space, certainly we would support that. Tomorrow, we are actually hosting the International Collaborative Asthma Network, which is researchers from all over the world, early investigators who are coming together. And one of the key areas that we're addressing is data and the use of AI in this space. And so I think that these are the kinds of things that we want to do in collaboration. And also, if you become aware of a company that is focusing their chatbot, or someone that's doing research and building a chatbot, again, perhaps there's funding that we can support you with to help achieve that. Perhaps there is, a way by which you, as the patient advocacy organization, can inform them to ensure that the instructions and the resources are consistent with your organizations, that they're using your resources to really speak to some of these different nuanced topics. Because I agree, I think that's the risk of things like chatbots and AI, and is that you miss some of the very detailed. But I also think that human beings miss that. If I'm completely honest, I've had interactions with healthcare providers where I'm like, they didn't get it. I sat there and they didn't get it, right? And so I think that we have to embrace these things and be at the table, as you suggest. Yes, Mitch? Make sure we get a mic, please. Sorry.
Thank you. Very nice, Tonya. So I really like, indeed, we can embrace it. We should be careful. But I think what can be interesting is to see if we can find patients that are actually maybe geek patients that would like to try out technology and actually see, okay, what are your learnings? What are your expectations? And actually, by sharing this across all the countries, we can actually make these kind of meetings much more efficient. So we actually have the bottom-up approach, the top-down approach, and by mixing this, we can advance faster.
I agree. I think a very important point. We need to introduce these tools to our communities and get their feedback and make them even better. I absolutely think that is, and we'll publish on that too, right? So we'll gather that data and then publish that data so that the general healthcare population understands what our preferences, what our needs, what our desires are when it comes to these technologies. Ruth?
Yeah, something that I'm really passionate about is that we have to consider diversity, equity, and inclusion is health literacy. And when you look at chatbots and AI, there is a potential to create pictograms and something that's a lot simpler for people who do not read well and do not speak well to be able to say, when she had all those choices, I was thinking, with AI, we can create pictures that somebody could click on something that might help with health literacy. And we shouldn't leave behind those who need the infographics and the pictures to communicate their issues.
So important and such a great point. I think, again, the opportunity to have visual representation and to communicate things in different ways, right? Whether there are AI tools that actually can listen to lung sounds, that can listen to heart sounds. And again, I think that the applications of this are almost endless. One of the pioneers in digital health is standing at the back of the room and has a tremendous amount of data that it's been gathered through remote monitoring of an app that her organization has led. So Shane Fitch from Love Air, if you'll take the floor.
Morning, everybody. Sorry for joining a bit late. It's actually very important, the point that Mitch mentioned. To get to being an e-patient actually requires a big process of learning how to adapt to using digital more regularly, whether it be a device, whether it be your own patient-reported outcome reporting, whether it be just that daily adherence, So from Love Air, we've been working with patients in hospital settings and children and parents with asthma, poorly controlled, bronchiectasis. And there's a lot of mixed outcomes because what we forget sometimes is the socio-demographics behind people actually really affects how much they engage in their own health. Yes. Another area that we're beginning to explore and work on now is a research project for applying AI to environmental exposures and its effect on our lung health.
And we believe that if we go down that route, the whole impact of air quality and temperature, which now is becoming very, very challenging for people, particularly with vulnerable diseases, is a very important path to follow. So we'd love to work with GAP on that project. We're hoping to complete the research abstract by the end of this month. We want to work with primary care physicians and maybe even pharmacists. And actually, we want to help make these resources sustainable. Somebody has to finance them at the end of the day, so we have to look at the business logic behind this, even from the patient organization perspective. So in the work of eHealth, there's masses to do. There's masses to do with healthcare professional capacity building. Yes. The adaptations that they have to make in hospital to begin to use these platforms is phenomenal. And that cultural change is something that we should all be working on together in a much more significant numbers. But thank you anyway.
Yeah, thank you, Shane. I couldn't agree more. Other comments? Did I miss one? Yeah.
So I'm going to translate for my colleague Dina here. So she wants to express that in Latin America, all the regions, there is like patient platforms that they're being implemented or digital solutions. So the beginning, the implementation, it's normally founded, but then the sustainability, the long term, those technical costs. I'm sure my Lobek sir knows about this challenge.
That's what Shane was just saying about that
so
sustainability.
So the challenge is the long term from Colombia, and my colleague from Spain, she also says that we should have empower the patients on the patient organization so they can give that knowledge to elderly patients in their own community that they don't have so easy access to understand features and websites and low literacy.
Such a great point, and I think it builds on what Bruce said as well as what Shane said around tailored approaches, right? So no longer do we have to have a one-size-fits-all sort of message and tailored our approach to our engagement and to our education. We can actually segment our community and say, for this population, this is the tool that works best. For this population, this is the tool that works best. And really have different strokes for different folks, right? But the sustainability, I hear you loudly and clearly that is a concern. And I think that it's something that we have to continue to say, what are creative ways we can fund these projects long term and not place the burden on patients and create greater disparities, greater social determinants of health, rather than close those gaps that exist today, right? Yeah. So with that, we are gonna close this session. We're gonna take just a very quick 10-minute break, and then we will come back for our industry panel before we then head to lunch at 12:30. So enjoy the break for the next 10 minutes. Any instructions from the team? No? Okay. Restrooms are out this door. Men first, and then go on past the lifts, and that's the ladies' room. And then, are there refreshments on this side? Yeah. Coffee and refreshments on this side of the wall here. So we have Suzanne Brandel from Roche. So welcome, Suzanne. You guys make her feel welcome. We have Mary Ruth Brimmer from Regeneron, Miguel Diaz from Sanofi, Michelle Warner from GSK, and Allison Evans from AstraZeneca. And again, I said this at the beginning, but not everyone was in the room, so I'll say it again. Without these sponsors, the Global Respiratory Summit would not happen. And more importantly, the day-to-day work that you all do would not happen. Our patients wouldn't have innovative treatments. They wouldn't have patient education resources and support. It truly takes the support and engagement of industry to make this community effort advance. And again, these diseases to be diagnosed, treated, and managed long term. And so I asked our industry panel to be here, and I forewarned them that no questions were off limit. No questions are off limit today. This is a safe space. You can get your questions answered by our industry partners. What we understand and recognize at GAP is that across the 108 organizations, across the 70 plus countries, there is a very vast difference in the way that you can ethically, transparently, legally operate with industry. So again, everything that is said here may not be as applicable to every single organization, but take what is relevant to you and don't leave without getting your questions answered. That's the purpose of this panel. So as we get started, I want you guys to introduce yourself, talk about sort of how long you've been in patient advocacy, and what country you live in, and the countries that perhaps you have responsibility for in patient advocacy, patient engagement. So we'll start with Suzanne.
Is this on? Can you hear me? Yes, perfect. So I'm Susanne Brandl, working in the Global Patient Partnership Network with Rush. I'm in advocacy and working very closely with patient organizations around the world, very much also in low and middle income countries since about 18 years. I'm with Rush 4 years. Yeah, so our key work is, and I would like to take up what you said before, Tonya, we're really trying to live up to the philosophy of everything for patients we do with patients. And I must say, it's a huge learning journey we are all on. You are on, we are on. I think I see a lot of nodding here. And so my role is in respiratory to really understand the unmet needs, to see how can we co-create together new solutions which are helping to bring the meaningful outcomes to the patients, but it needs all of us. It needs all of us to work together, to find these solutions together and strive forward. And then the other role of me is kind of bringing in all these insights and the understanding so that my colleagues in all the different departments also understand what we have to cater for and what we need to know to build the right solutions. That's maybe where I stop.
Great. Thank you, Suzanne. Michael?
Thank you, Suzanne, very much. Well, my name is Miquel Diaz. I am really pleased to be here, and thank you for organizing this panel, because normally we were expecting the patients to be here, so in a humble position, we are really happy to be here today. So I am working in Sanofi for more than 20 years. My role is Global Public Affairs Head for Respiratory and Gastrointestinal Diseases. I live in Barcelona, Spain, despite I have a global position, and then I've been working for patient advocacy for 8 years. 6 of those years were at a national level in Spain, so that's why I know many, many people here today. And then the last 2 years has been a global position. And then, my role is within the company in public affairs. So we have this patient advocacy and then policy advocacy as well. And also the philosophy of Sanofi is really have trust long-term relationship with you, be part of the community, also co-create, as she was saying, so not just a sponsor, but co-create projects to also highlight the policy insights and to how we can push policymakers to take the right decisions. And then we will talk maybe later about other important things, which is scientific exchange. I just put it here, but I'm sure later on we can develop that. I give the word to my colleague, Mary Ruth.
I will not let us forget scientific exchange. Mary Ruth?
Hi, everyone. My name is Mary Ruth Brimmer, and I work for Regeneron. And I've been working with patient organizations off and on, directly, indirectly, for probably around 18 years since I started at the industry. But the last several years, I've been working directly in this role as patient advocacy for Regeneron Pharmaceuticals. And so I live in Connecticut, US-based, but I also cover both the United States and global, thanks to our alliance with Sanofi. So again, very similar to what others have said is, we just, the patients and their experiences and their unmet needs are at the center of everything that we do and how we think about our business and what we want to hopefully help to work with you all to find solutions and help those communities. So That's it.
Michelle?
Hi, everybody. Yes, I've been with GSK for 29 years, so I'm a little bit of an old-timer.
I don't understand how that is when you're only 29 today. I just don't see.
Yes, I joined the UK company, and I had the opportunity, it would have been about 5 or 6 years into that role, to pick up on working with what was then the British Lung Foundation and Asthma and Lung UK. And fast forward a lot of years, I joined the global team about 8 years ago, and actually I had the privilege of this role being shaped so that it included things like the advocacy world for patients, but also some of those societies such as the ERS, IPCRG, some of the other medical societies. So it's been a really big job until this year, and then thankfully my colleague Max has joined the team, and I have another colleague called Rian, so we are growing, and my job very much is, as everybody else has described, to bring that voice of the patient to our work, whether that's the insights we need or actually telling our story. That's how much better to do so with the patient at the centre. And then in terms of really looking at where are those connections with our industry partners and with other organisations such as GAP. We've got the chance to work with a really big network in JSK. We have the Global Patient Affairs Network, where all my colleagues that sit in the countries where you are doing your work with real patients, I have the chance of sitting on the network with them. So we review all of the opportunities, and together we choose the ones that we think are the most likely to make the biggest impact to patients.
Great. Thank you, Michelle. Alison?
Thanks, Michelle. Hi all, my name's Alison, and I work as Global Policy Director at AstraZeneca. In comparison to my colleagues on this panel, I have not worked at AstraZeneca or in industry for a number of years. I actually joined just 3 years ago during the pandemic, and it was my first industry role. So when you ask the question, Tonya, how long have I worked in patient advocacy? About the last 15 years. But until 2020, I was on your side of the table. So I worked for patient advocacy organisations, leading both research and policy teams across both the dementia space and in oncology. So I know that side of the fence as well as this side of the fence, and hopefully we can share some more insights as we go through today. In terms of my current role, so I focus both on policy and advocacy, so slightly different from some of the other colleagues on this panel, but how can we work with you, with other, you mentioned, IPCRG, wider stakeholders, and look at where are the opportunities to improve care for people living with different respiratory conditions? How do we break down some of those healthcare barriers? And how can we come together, and you touched on this earlier, Tonya, in that one voice and make sure that we come together as a community? And it'd be really great to have that discussion today. Where is that sweet spot across the Venn diagram where we can have the biggest impact working together?
Yes.
Thank you.
Thank you. So it's very fascinating to me, the backgrounds and the collective experience that we have at this table. And when we use the term global, okay? So global means the entire world to most of us in this room, but not necessarily so in pharma, right? Not necessarily so in your organizations. So explain to us where your role sits, and also perhaps how the patient engagement philosophy has evolved within your organization in the most recent years. Anybody want to take that first? Yeah, Miguel, why don't you go first? Yes.
Well, thank you for asking that. Well, I think that's a very relevant question, and I think we are evolving year after year, and the good thing is that there are changes happening and we see them. And what Suzanne was commenting, it's also important that our other functions in the company are understanding what we do, why we do it. I would say that one of the things that has changed clearly is we are trying to change the policy, the internal policies, to make the work internally and externally easier for everyone and to make things happening. We were from a mindset of risk. Oh, this is very risky, we can be sued, you cannot do this, you cannot do that. So moving from the mindset of the risk to the mindset of what if we do that, of the playing to win, trying to push a little bit the borders. Another thing is that the policies were using wording that was not clear. They were putting in the same basket patients as patients advocacy groups, and this is not the same. The level of professionality that you have and the level of knowledge is different than an average patient that gives the testimony of their life. So also trying to change that in the policy to make what we can do with patient advocates probably different than what we can do with just an average patient. always with the interest of the protection of patients' expectations. So that's another thing it has changed. And then another thing is about what is the level of, the type of interactions we have with you. Before we were more in a more victimism vision of the patient, the typical patient testimonial that come to the company to explain what it means living with this condition, which still is very important for everyone to understand what it means from a patient perspective, but that was more from the victimism point of view, and I think that you are such a big fighters that I think the company is changing the mindset also to see you as fighters, as warriors, and put you not as a victim, but on the other side as the superheroes that you want to reach something. And I think that mindset has changed as well. I will stop it here to leave my colleagues, but another topic, scientific exchange, is something that's also evolving. We can tackle that later on if you want.
Yes, and at Sanofi, patient advocacy, does it sit as a function more of like public policy, government affairs in the organization? Is that where it's housed?
Yeah, and it's true that each company is different. So the title that we have is not patient advocacy, it's public affairs. And public affairs has these two legs, the advocacy part and then the policy part. We are within the corporate organization with also communication has a big important also because they amplify what we do. But indeed, it is not only advocacy, but is also policy. And then we have another team. We are giving support to specific therapeutic areas, so that's why I'm respiratory. But then there is another team that is corporate public affairs, that they are above TAs, above therapeutic areas, trying to also push the policy, let's say, regardless of the TA that is interested.
Yeah. So this is important because who you engage with in the organization, you know, sometimes they may be in government affairs and have more of a policy perspective, lens. Sometimes they come from a communications background, right? So Michelle, I know historically, GSK, that is where this function has sat. So why don't you speak to it?
Yeah, so we have the Communications and Government Affairs team, and sadly what we kept seeing happen was that there wasn't enough resource, and this takes a lot of work. So we now have advocacy, patient work, all sitting under our medical affairs organization, which is where I sit and Max sits. It's quite interesting to think about how things have changed. That was one of your initial questions. And I agree with you entirely, Miguel. There's a definite shift towards what can we do rather than what can't we do. Yes. But I still think all of us are a little bit frightened, more so to be working in a space that we're less familiar with, where everybody says, oh, you know, whatever you do, don't let us ever be in this situation where we could get accused of ABC. So it's a bit more of a sensitive area than working with healthcare professionals. And so I often find I'm working with colleagues who come to me for advice, and they'll say, I really want to get such and such off the ground. How do you do it? And I just keep saying, have the conversation. You know, if you're working with colleagues of mine that sit in the different countries, be a little bit, I would say, cognizant of the fact that this is new for a lot of people. The last thing to say is we have, there's also this patient-focused development section in GSK, and it's really worth you knowing about them. So it's headed up by Dr. Andrew Benzie, who has got a team of people, so this is across oncology, across respiratory, across our vaccines organization, and their entire job is to work to take something that could be a concept in a lab all the way through to development when it comes to a medicine. So very asset medicine vaccine focused. But they partner with myself and with Max in respiratory because actually the baton has to get handed over much earlier these days, because in medical we want to be able to bring the voice of the patient to the design of a medicine so that the unmet need is addressed much earlier. So there's a partnership there that takes place, and I think I've already mentioned it. I, alongside my patient-focused development colleagues, sit on the Global Patient Affairs Network at GSK, so your stories very often land in that group as examples of great work that's going on across the globe, and I'm in a global role.
Great, thank you. Alison?
So Tonya, you mentioned an interesting point, like it depends who you engage with, right? We all sit in slightly different functions in different organizations, but The one thing that's really struck me is when I worked on the patient advocacy side, I used to talk to many industry colleagues most weeks, and you thought, oh, I think I know them quite well. And then you come in-house and you go, imagine if I'd been slightly more proactive in terms of being very, very explicit, saying, I want to make sure I have updates on X, Y, and Z, because there's things, when you work outside of this world, I could send you something, Tonya, I could send you something, and that's how you build relationships in terms of that sharing of information, building of trust. But there's so many things we cannot share with you unless you've proactively asked for it. So I guess my ask...
So to the note of scientific exchange, which was said earlier, and I just wonder if everyone in the room was as naive to this as I, that they cannot send us their data, their press releases, their information, without us asking on an annual basis in writing for that information. So if you have not done so, task number 1, write it down. Send an email to your industry colleagues in each of these organizations requesting ongoing scientific exchange in your disease area. And that's the terminology, okay? They cannot do that without us initiating it. So very, very important takeaway from here. Okay, great. Let's see, anybody else that wants to speak kind of to where your role sits or a patient engagement philosophy? Suzanne?
Happy to follow through, and as mentioned, every company is very differently set up on that side. So we in Patient Partnership, actually, we are in a matrix organization. So we are a patient partnership network versus function. So as a network, we are sitting and linked directly into the product development, medical affairs teams, but working really from early to late stage development up to access policy and what we also call life cycle management. So we are sitting in all of the teams, cross-functional teams, bringing in the patient perspective. So we are always the ones. Can we ask patients, what is the outside in? How do we bring in the experience of the patients? And I would like to pinpoint here actually to Mercy as well, who is my colleague helping in respiratory, who will be here as well. So I think that is a very important point, which was mentioned also by my partners here. So we try to really bring in the voice as early as possible into also the development. So really study design, materials, all the things which can be done, because if we don't start working on developing the right products and solutions, and I'm not only talking about treatment, there's all about solutions, we heard about digital, and have this culture mind shift being internalized, we cannot start with addressing the unmet needs. So we need to really bring it in. And I can tell you, it's a learning journey also on an internal level to actually talk to our scientists and say, like, we don't listen only to the HCPs and the scientists. We need to also listen to the patients, the caregivers, the advocates, and everybody here in the room. That's maybe...
Yeah, thank you. Srila, if we'll just give that one to Allison so that we've got one on each end. That'll make things a little bit faster here. I'm cognizant of our time, and I want to get to your questions. So one of the questions that I posed is, what is your greatest challenge internally with your organization stakeholders in explaining this role, explaining our world as patient advocates, and externally in actually working alongside of us? And don't hold back, because honestly, we're not going to take offense, right? No one's here to take offense. We want to know, what are the challenges that you see from your role, both internally and externally? Who's going to go first?
Maybe I will start from internally. We have a lot of challenges, a lot. I will say bureaucracy maybe is the biggest. We need a lot of anticipation, because always, despite those activities we do are not new, always there are new things that we didn't know that we were supposed to do, and also with that mindset of, okay, this is not possible, that required time, a lot of time. And then, of course, externally, I would say, well, we were told that in public affairs you need only 3 years to shape the market, and the proof is that that's not correct. You need 4, 5 years, indeed, ongoing, work to make something happen. So maybe we need to anticipate even more with you. And then for challenges, I would say maybe, honestly, from the patient advocacy, we don't see that so much. We see it more from the medical societies, that they see the industry not only as a funder, but also as a strategic partner. We can bring to the table not only our experience of, well, if you put together all the years you have mentioned, it's more than 1 century, I would say. But honestly, the network that we have, the experience, so our brains can help as well. And I would say that the patient community already see us like this. We perceive that we are well perceived by them, but then with medical societies as well, that's a challenge, and we are working in progress with them as well. So I leave the word to my colleagues, but there's a lot of...
You know, I think it's such a poignant point, Miguel, because a lot of times with any relationship, right, if it's very transactional, if it feels like you're only seeking one thing, have one agenda, it's very one-sided. And I think that what I hear you saying is that it is this longer-term relationship. It's committing to a space. And I know that in our space, right, honestly, Sanofi was an unknown. Regeneron was absolutely an unknown in the respiratory space a decade ago. And I often say the work that's been done to demonstrate we are here to stay, we aren't going anywhere, we're investing in a pipeline, you know, and again, no offense to GSK or AstraZeneca, who's been in this space a very long time, but the very evident commitment of the last decade to be that constant in this space, because there are other funders, not in this group, but who are in today, out tomorrow, and we all know them, right? They ring your phone incessantly for a year, and then an asset falls by the wayside, and they forget that they ever met you. And that doesn't feel like a partnership, right? And so I really appreciate what you said there. It's very meaningful to me. But I think selling that internally is oftentimes a challenge. Yeah, Mary Ruth?
Yeah, as you mentioned, and I'll bridge from that, it was the perfect bridge, is, you know, I'm at Regeneron, and it's a very lean organization. You know, it's been around for 35 years, started in the United States, and the president and chief scientific officer are the founders. They were the ones that, you know, developed, they're the scientists behind it. So we're a heavily science-focused company, but the mission is still the same. It's doing well by doing good. And how do you do good? By using the power of science to make new medicines to help the patients in need. And so with that, you know, I've only been there several years, much like yourself in this space, but what I have found internally, the challenges are, now it's like a light bulb has gone off, and everybody wants a piece of what is the patient? What's the patient? Hey, but they don't think of the patient until the end. And the biggest challenge for me is helping them realize with like our clinical trial optimization team, don't call me at the end after you've created all the clinical trial patient materials and ask me to take a quick look. No.
Not going to turn out well.
Yeah, let's bring in you all, the organizations that have the understanding and knowledge of what those patients are. Let's bring them in earlier. You know, I'll make an example. Mary Jo recently, you know, our consumer team, marketing team wants some DSE campaign information to look at. And, you know, again, they come to you at the last minute, and then it's all, you know, it's a fire drill. Hurry, 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 and look. And thank you to those of you that get those requests and those answers and help us out. But it is a two-way street. And so, you know, we want to be clear that we want to work with you all and support the communities you are. Sometimes it can be challenging depending on, you know, the external factors, which kind of throws me over to the external side, which is just, you know, as Tanya was mentioning, you know, GAP, I see many faces, COPD Foundation, AFA, that we work with really regularly, do such a fine job of requesting science-to-science meetings. So you all really understand what our science and pipeline is, which then helps us have better conversations and more of a partnership of collaboration and discussions to figure out what is the best plan in your area for your patient communities or, you know, or not. So we really appreciate you all doing your due diligence as well as us. And also don't be afraid to ask us a ton of questions. I mean, we love the proactive approach because, you know, we're going to be very proactive back to you as well. So it's certainly a bi-directional feedback loop, but we really appreciate that.
Yeah. So Allison, maybe next, you talk about any internal, external challenges that are slightly different.
Yeah, thank you. So I guess internally, I think we've spoken a lot today about policy change. It doesn't happen overnight, right? But we work in big organisations that have many different functions, some of which you can see change much quicker than you can on policy. So I think an internal piece is really making sure that case that it takes time, and to your kind of wider points, we need to commit to that to see that change in terms of policies changing, environment changing, so that care can improve for patients. It's not the same as some other areas. So I think that's where it's slightly different. And I guess externally, we've touched on some of this morning, there's such an unmet need in this area. You know, we've spoken about COPD, and it's the third leading cause of death. We've seen respiratory diseases go under the radar, and I think that's where we have the biggest opportunity. There's so much passion in this room, there's so much passion in this community. How do we all make that change externally? So the improvements we all want to see, so we're not saying, how are we still seeing late diagnosis? How are we still seeing this? Why aren't patients getting access to that? That's, I think, the challenge externally that can then also come back and help internally, because you see the momentum, which we've all seen in many other areas, and respiratory, we all know, really, really needs that.
Yeah, great. Thanks, Michelle. Anything different to add?
Yeah, it's probably a little bit different because, you know, 50-odd years that GSK have been in respiratory, and, you know, I joined when it was Allen and Hamburys, and we were good old Ventolin, Bectide and all those things. So it was a very, very long time ago, and I think there's a little bit more complacency perhaps about respiratory in our company, or there has been over it's changed recently, which I'm very happy about. So
we
that's
all
been
are happy about, Michelle. Very happy to see that return passion.
So that has been one of our internal challenges. And then the other thing is that it's so big and there are so many stakeholders. So I think I've got something over the line, Ruth's nodding at me, that's very simple, and then all of a sudden somebody will say, you have checked with legal, or you have checked with such and such. And these people don't have this top of their priority list. So we end up having to really work with much longer timelines than I'd love us to. But my message is, let's not give up, because it's quite easy to think it's taking too long.
Yes, I often say it takes twice as long and at least 3 or 4 times additional blood, sweat, tears to get things across the line. And, you know, for those of you in the room who are your fundraisers for your nonprofits and are writing those proposals and submitting and resubmitting and going through a review on this and having discussions about that, it can be exhausting, and it's easy to want to give up. I've been there where I've been like, okay, this is not worth the headache. And yet, if we stay the course and we continue the open dialogue and lines of communication, somehow we find a solution. So, yeah.
Maybe one additional channel, so I can, or challenge, I can sign off everything which has been discussed here, was something which was mentioned also by Shane earlier today. It's about the cultural shift, the mindset shift, but also thinking sustainable solutions. And sustainability means long-term thinking. Everybody knows that we have also, of course, annual goals, annual budgets, and so on. But if we want to make a change, and if we want to shift from transactional to more transformational, we need to think much more strategically.
Yes.
So also, when you come to us, we need to understand what is the strategy behind, what is kind of the outcome, the impact which needs to be reached, because everything we are trying to do, the desire to co-create together, we need to kind of also prove to get the money and the resources, first of all, that is mutually beneficial for the patients, for society at large, with the healthcare system in mind as well, and the business. So when I need to kind of go back and ask for the budget for the different supports and the collaborations and partnerships we are hoping to build further and expand further, this is something where I need to have answers. This is when I need to show what is the impact we can create together, and how can we make sure that we also understand what the value is, so that we can actually make the resources being available.
You know, Suzanne, this is something that I have seen dramatically change in the last sort of 3 to 5 years. The absolute requirement to inspect and to measure and to evaluate what you're doing and provide that feedback loop on an ongoing basis, right? There is no just them writing a check and walking away and you don't ever have to talk about it again. That doesn't happen. And it used to, quite honestly. But it doesn't happen any longer. And so they, again, must have compliance, legal, medical oversight, sign off, but then the evaluation, the closing of that loop of how it actually impacts and makes a difference in the lives of the community that you serve is really important. I know we're going to be stretched on time, so I want to give you kind of if one thing that you wish the people in this room, the patient advocates that are going to walk out of here, one thing that you wish that they knew, realized, understood. I think, to Mary Ruth's point earlier, one thing that I've realized, I used to think every organization was pretty much the same, and I now know there is no one size fits all in their space either, right? So they are working across a portfolio with different priorities, with different resources, and a lot of it is about product life cycle management. And so maybe if someone will address the way you think about in your organization funds product life cycle management, that would be really helpful for this group to hear.
Well, maybe I can start. So we have developed what is called IPE, Integrated Patient Engagement, and that's led by public affairs, but we are involving many other functions in that process. So of course R&D, and then of course the medical, because phase 4 trials, etc., market access, and also other functions in the company to make sure that we are integrating the voice of the patient in every stage of the journey of the drug, even at the last stage of the drug when generics are coming, how we can also protect them. So in that engagement, I mean, it creates the need to change policies and to align all of us and to put different functions together around the table about how the patient voice could be, as you were commenting, early enough to make sure that we are doing the right things. And we come from a culture that we were asking the doctors what patients think, and we were not asking patients what they think. And it's not always the same. Yes. Maybe the topics are there, but the prioritization...
We agree. We agree. Couldn't say it better myself.
Prioritization is differently. And sometimes when you ask patients, there are other topics that doctors never thought, especially psychological support, for instance, as an example. Yeah. So I would say that this integrated patient engagement is where we are, supporting all our efforts to make sure that all the company is patient-centric, and it's not just a word, but it's something true. I would say that.
Great, thank you, Miguel. Michelle?
I'm going to try and give it a little bit of an example, just so we could imagine. So imagine a world whereby, I don't know, one of the companies comes up with something that might work in Alpha 1. So then what happened in the old days is that there would be a whole heap of scientists doing a whole load of work, as you described, but there wouldn't necessarily be what does the patient need from this. So we now have something called an Early Assets Global Medical Affairs Lead who works literally alongside those scientists. And that particular very early stage asset will have somebody from the medical bit pulling that through the whole way, from insights to evidence generation. So you could get to the stage where this is licensed, and then actually we need the sort of evidence that's meaningful for patients, so there'll be publication work that's done there, etc. And then there'll obviously be a whole heap of education, etc., etc. So across the whole bit is medical, working from start to finish. But you've always got, of course, you've got your representatives that do some promotional work that have to be part and parcel of that life cycle management plan. You've got your, what's the other bit? Blank, head's gone blank, blame the menopause. So basically, it is one of those things that's become so much more patient-centric. I know what it was, that we have a patient-centricity plan from start to finish, and then the patient organisation bit is part and parcel of that too. Yeah. So I hope that sort of brings it to life a little bit if you were somebody with Alpha 1.
So this may be the elephant in the room in some regards, right? We have very tight regulations, and particularly being UK headquarters, we have one of the strictest regulatory codes in terms of the Association of British Pharmaceutical Industries. When I think back to when I worked on patient group side, you wanted insights, you could send out an email to your members and supporters, and you got it in an instant, and within 48 hours you could have hundreds of people answer a survey. We can't quite work in that way, so there's also, to your wider points, there's longer lead times and ways in which we can do it. So I think hearing from you, as we mentioned earlier, when you want to work with us, those proactive requests, to your point around scientific exchange, we can then be better partners to you. But I think it's also just flagging that, why haven't you done that? Some of those steps, to your point, we need to plan it earlier. We need to look at longer lead times. It's a very different way of working, which I've learned coming from your side in terms of the lead times you work on things and also the things we have to do to protect you as partners as well as to protect ourselves.
So very, very pragmatically, what does that mean? In that I can't ring you up and say, we're doing an event next month and I need you to support it. That doesn't happen. It doesn't happen. That is generally a 12 to 18 month, depending on what time of year, where you're doing your budget planning, you're putting in those plans. I know we've already had, as most of you probably have, discussions about 2024, and here we sit in the first week of September. So it is a very lengthy lead time and conversation around what we're hoping to do, the sustainability of those programs and events and things like that, yeah.
I would genuinely be asking, what are your strategic objectives?
Yes.
Person ABC. And then actually you can see very clearly where the overlap is. And it might be that you could get some help more sooner rather than later. It doesn't all, we have had those examples.
They do happen.
Yeah, they do happen. But if you really understand one another's priorities and you really understand what it is that's central to the plan, you will find yourself in a situation where you get a much more receptive partnership outcome.
Yeah, so I know we want to get to some of your questions. One of the things that I've noted is, again, this effort to engage earlier and more often. But there still is this window of when an asset is moving through phase 3 and headed to market where you're turning up the dollars, right? And that's just the reality. That is where the floodgates sort of open and the resources are there to build the market more aggressively. And then there's about a year and a half post-launch, and then it almost feels like the bottom falls out of those budgets from our side. And I'm just speaking, from my experience.
That's what, yeah.
Is that reality? For most of your organizations, the way you sort of invest and sunset different programs?
I was going to mention that earlier when others were speaking. Think of it like a bell curve. And if you look at any industry, any company's, respiratory pipeline, and you see where they're at, just what Tanya was saying, very, very early on, we're going to be working with our clinical teams in the phase 1 and phase 2. It's like patient materials. Come around phase 3, if we're not already in that space, that's where a big sweet spot starts for many of you. If a company is new in the respiratory space or new in a different indication or therapeutic area within that respiratory space, that's the sweet spot because they need to start engaging and better understanding. And oftentimes it's the patient advocacy, public affairs folks, if not some of the clinical team, but it's really that becomes the heavy burden becomes on us, and that's where we get really excited and super pumped because then there's a budget that starts getting attached to that. So we're not just having conversations with you all, but we're actually thinking, and oftentimes it's big around awareness. Because as you all know, until something is closer to being approved, we really can't do too much pre-promotion so there's a fine line from legal and compliance and regulatory space there too, but a lot of awareness is where, we could do a lot in that early. And then as you get closer to that, PDUFA date, submission, and approval, that's where the budgets start growing more and more because it becomes more of an opportunity. And it's not about, I don't want it to make it sound like it's a money-making thing. It's about, we don't want to engage and get the patient community and all of you too excited too quickly if it's not going to come to fruition. That has happened. I think everyone's probably been burned at some point or another, especially if you've been in rare. And that's something that we have to also walk a fine line, and usually we're very transparent. But if things work and we can bring new science and medicines to the public and the patient communities, yes, that's where we obviously, and that's when it's not just patient advocacy, but then our other, consumer teams and medical colleagues, there's patient ad boards, there's, a bunch of different patient ambassadors, and all those things start engaging. And so to your point, that's the big part of the bell curve. And then it does start to slant down. And again, it's not about, again, well, we're having less money and, there's nothing much more there to do. It's really usually just a matter of, from a patient advocacy, I can speak from my side, once we only have so much education out there, what's the best next move? It's about improving the access for those patients. And so we kind of have to start shifting gears and moving into more longer-term efforts
Aims
that
and
just
goals,
take longer and are a little bit slower.
So action number 2 for each of you in this room. If you don't know the pipelines of these companies, look at them today. Look at phase 2 projects, phase 2, phase 3. That is the sweet spot. That is the start of that bell-shaped curve. And that's when it's most opportune to be engaging and present. That's on you. That's not on them to tell you what's coming down. That's on us as professional advocates to know what is developing in our space.
Antonia, if I can connect the first request with the second one, they can also ask for that to us.
From us, yes.
So can you present your pipeline? Can we know phase 1, phase 2, phase 3 trials?
Yes.
The more specific
and it's public in most cases as well. So yeah.
But the more specific they are, then the easier is for us to satisfy that need. That's another thing.
Yeah, absolutely.
Can I just make one summary on that? Because I think it's really about dialogue. It's really about, and dialogue we can all start, but it needs to be also built on the mutual interest. So if there's interest, if there are questions, just come to us.
Yes.
Because we want to build that open and transparent dialogue, but we also have certain limitations. So let's go down there, and that would be maybe one wish from my side. Let's try to understand both sides. So us kind of committing to help to understand actually also where we come from and where our boundaries sometimes are, but also the other side that we really understand.
As with any relationship, right? It's about communication, mutual respect, trust. I mean, it's the fundamentals of any good relationship that are at play here. And then I think where the best partnerships evolve over time. I know that people have questions and we're short on time, so maybe 1 or 2 questions from the audience, and then they will be around throughout lunch and the rest of the day, so please get your questions answered. Ashok first. Ashok. Sorry, okay. Someone else had already trumped you. Susanna? Ashok, you're next.
Thank you very much. The kind of culture that you are driving in your organizations, how can we make sure that for working with the patient organizations and supporting them, how can we make sure that that is cascading to your national representations? And if not, how can we work together from GAP and IFA and I don't know, to build that connection, because often we receive requests from our members that these fabulous companies are not, you know, necessarily so supportive, or if there is some collision at the national level, not to leave it like that, but bring those two parties together to help to understand each other. And how can we really do that concretely and not just and follow up on that, and what are the problems there and how can we overcome them? And the second is that not all of the companies have a representation in all of the countries. There are sometimes some regional representations, but then that brings language barriers sometimes. So how can we make that connection?
Yeah, and I can say, just briefly to address that, I mean, we've had numerous situations where I've rang everyone on this panel to say, who's the country contact for this country, for that country? So use GAP for that purpose, and we'll be that broker of fostering those and connecting you appropriately, but maybe to address the sort of difference of in-country and prioritization of country, because not every country is prioritized the same within your organization. So speak to that, please.
Yeah, well, this is a very relevant question, Susanna. So indeed, coming to your first question, we are global, but of course, we are a limited number in our team. By the way, I have Alessandra and Christine from Sanofi at the backward, and they are also here from Sanofi. So we cannot having, let's say, monthly calls with all the countries. So we are prioritizing. So the ways of working, of course, we have public affairs team in each one of the key affiliates or countries, and then we have monthly calls with those people, and then there is a good interaction, and we know what it happens in the country. But of course, it happens that when we update policies at the global level, and then we send to all the affiliates to adapt those policies at the country level, you always find barriers. No, you cannot do this here. Why? Well, you cannot do that here. And then when you say why, and you realize that maybe some of those barriers can be removed, but maybe it takes 1 year or 2 years more that this update at the global level has fallen into the country. So we understand that that happens. I would say that for your question, you can count on us to then cascade down. Another issue that you have facing, and we see that, is who is the contact point for that company for you? Because every time now you get contacted by R&D, you're contacted by medical, you're contacted by public affairs. So we are also trying to protect the relationship and try to be only one contact person for you to know exactly who you need to call. And let's be efficient, and then we can then disseminate your question to the right person or the right country if there is a barrier there.
And I can say from our side, there's been times with each of your organizations where something sort of backdoored and got to me, and you guys are like, what? You know, I call you, I have no idea that was going on. I didn't know, you know. So making sure that whoever that single point of contact is, that, you know, there's that common bi-directional, here's the things I'm being pulled into, the things I'm being asked. And it's not so that they become the bottleneck. That's not the intent. It is so that, you know, there is coordination. Because I have monthly touch points with everyone on the panel here. And sometimes that group is just us, one-on-one. Sometimes there's 10 or 20 people on the line. But it just provides that central point of contact and communication that is more effective. So, one more question from Ashok, and then I think we're going to have to break for lunch. And again, please get your questions answered in the... Sorry, Ashok and then Vildana. Okay, we'll take two more. And then
Well,
the
I'm
rest will have
Ashok.
to happen at lunch. Sorry.
I come from India, and the point again is the countries are at a different level of development. And what you rightly identified, yes, the policies take a lot of time to percolate down. But there are certain common things that we need to understand. One, for all these years, the research has been focused primarily with the industry and the medical community. And especially the pre-marketing trial. I'm not talking about the phase 1, 2, 3. It's the pre-marketing trial, because any new drug getting introduced into the country, you need to do a pre-marketing trial. So I believe the pre-marketing and the post-marketing trials, they are really non-risk business. So the patient organizations should lead these programs, because ultimately they are going to be the best people to define the safety profile. Because by and large, what we have found is it's all focused with the medical community, whereas it's primarily the large patient groups. And so if you have a patient organization in a country which is a credible organization, I think they should be the focus of your trials in the pre-marketing and the post-marketing group.
Spoken exquisitely by a doctor in the room. Thank you. Thank you. To recognize, again, I mean, I love this because this is a provider who's saying, this is the appropriate place. It's not the medical community that always has to be the go-to for these types of research and findings. I mean, go where it is, and that's oftentimes...
There's just one more observation that I wanted to make. One, all throughout the discussion, we've been asking the patient groups to become proactive. I would request the industry to become more proactive, especially because you have the public relation program. So when you say public relation, it's going to be pick and choose. You pick and choose somebody that you feel that he has the knowledge. But if you have a program where you have a patient group, again, a credible patient group, always there in your public relation program, which can be a non-paid job, you can always invite any one of us in different parts of the world. And when they are there, I think you will probably benefit from their presence rather than you taking your own decision in terms of industry. Who is the person right to give you the patient inputs?
Thank you, Dr. Gupta. Thank you, thank you. Vildana?
Hello, my name is Vildana Mukic. I come from Bosnia and Herzegovina. And just one comment, and then I have a question. First comment relates to Dr. Gupta. Definitely, I believe when you mentioned the pipelines, I think maybe it can be too late when it's about pipelines. I believe that you should include us during your strategy development, and that means you care. So, for instance, I think, sorry, this is a big step that you came today to talk to us, and what Mr. from Sanofi has said, I totally agree. You said it's a new era of patients. They're well educated, you know. Now, yes, we are not just patients, so we are patient leads. So we need to be educated, and we need to know all terminology. We need to know how everything functions, even your medicine. And very often, you know, physicians would say, oh, are you my colleague? We would say, no, we were forced to learn. So the point is that I definitely agree. We all agree that you're very important, and we are all very important. So we all have to bridge the gaps between policymakers, media, patients, pharma industry, and physicians, because we are in one circle in order to make a change. And that's the real change. If you just want us to approach you, I mean, that's already too late. The things are not, you know, made on the right level. And my question is, sorry for Sanofi, but this is, I come from Bosnia and Herzegovina, you know, and you were talking about shaping the market. So we have like you said 4 to 5 years to shape the market. So for instance, in my country, you shaped it, and then you left, like most of you. Okay, we understand that part of the business and things, and you have to, we understand. But the point is there some level of responsibility for how long you should leave when you go? I don't know how to say that. You used to physicians to write your medicines, and they would write it, and then you just, you know, left the patients. We feel like that, you know, because we cannot communicate with you. You know, it's some distributor who doesn't care. So I think also you should think about it when you're leaving the market, you know, and you have good treatment, what happens with patients. So thank you, and sorry for taking
Yeah, and Mikael, I'm going to let you respond to that, but I am also going to say that I've had now 3 conversations with advocates in this room. It's not just Bosnia. It's happening in Nigeria. So this is happening across the world. It's a real concern for us as a patient advocacy community that, you know, there is that investment, there is that bell-shaped curve, but as you tell it off, how do you responsibly, respectfully do that? Miguel.
Well, thank you for being frank. I was told that this is a demanding and challenging audience, and it's true, and that's what we want, transparent conversations.
I told you, I warned them that we would not pull any punches.
And that's what we really want, otherwise the conversation doesn't bring value. So for the first part of your topic, just as an example, we recently did a patient panel, that's how they call it, about atopic eczema, not respiratory, trying to see all what we have in phase 1, how does it look like, and what are the gaps based on the needs of the patients, for the company to see what are the next step to, you know, purchasing new companies. So already integrating the patient voice earlier, even before phase 1. So that was for the first. So we are in that area of the same mindset that you commend. So about budget and investment, it is a challenge because in the same way that you are fundraising to the industry, we internally as public affairs, we need to fight for the budget owners, and not always we are the decision makers. And it's true that at some point when the products are very mature, there is no budget anymore. And it's true that we focus a lot on initiating projects. We put a lot of energy for any project that we start, but maybe we don't put so much energy on how we end the projects. So that's a question that I cannot answer today, but I think it's so fair and frank question that we need to focus also when we are foreseeing that something is going to end, how we can mitigate that impact. And that not only happens with the patient advocates, it also happens with the medical societies. I remember when I was working in marketing, how medical societies in cardiology at the time, they were so mad about us because we were not able to do so many congresses or things. So this budget being not endless, it's an issue for many stakeholders, and we understand that we should also manage that better. because we don't want to break a relationship that has been built for so many years. So thank you for challenging us. It's not solved yet, but we will think about.
Yeah, so again, I appreciate the fact that we can have these crucial conversations, these challenges around the way that things have always happened, the way that, you know, we've had to navigate different hurdles in the relationship between industry and patient advocacy. The evolution of the last 3 to 5 years, I mean, I've worked now with each of you for at least that length of time, Suzanne being the shortest tenure of the group, but it does develop over time. I mean, the way that we interacted day one is not the same as we do today, 3, 5+ years down the line, and I'm so grateful that you guys invest in that, in truly building quality relationships with our patient organizations, respecting, demanding. I said this at the beginning, I'm going to say it again because you're up here. There was a day where I was basically on my knees begging for a patient to speak at this Congress, and the door was slammed, and I was told no. And this time we have 3 symposiums, 2 posters of patient presentations because of your influence with the medical societies. So I think that this is a key way that, again, we can look at, we're maybe not where we want to be in every single facet of internally and externally addressing the challenges, but it's a process, and we're in progress, and I am extremely grateful to each of you for going along the journey, for helping us and supporting us, and for your willingness to take the tough questions today. So thanks. All right. We are going to head to lunch, and I'm going to ask Victor to give some instructions. We are going to have to cut lunch just a bit to stay on track for this afternoon. Victor?
Okay, before we go into lunch, I will need to ask you a question now regarding the dinner. So please raise your hand if you're gluten intolerant or no? No one with gluten? No? And how many people of you are, one? And how many people of you are vegetarian, vegan, or cannot eat meat? 2, 3, 4, 6, 7,
Raise your hand
8,
high
9.
on that so we have the right count, please.
3, 4, 5, 6, 7, 8, 9, 10, 11, okay? Okay, thank you. 12.
Yeah.
So the lunch now is in the first floor, so you can take the lift or the stairs. It's just under here. Yeah, 1 floor down.
We will be back at 1:30
1:30
p.m. Okay, we'll get started again at 1:30. Enjoy lunch.
Just vegetarian, not a vegan.
Again, cultural norms and differences, right? If I ever get a 20-minute lunch, I consider that a luxury. And in Europe, that is an insult, right? So I think I like the European way better than the American way when it comes to very, very rushed lunches. So, yeah. Yeah. Yes. Yeah, most of the time I'm eating at my desk while I'm multitasking, yes. So it's nice to just have lunch and to chat and catch up. But welcome back. We are going to enter into the time of the day where you guys get to go to work. So I'm really excited about our breakout sessions. As I said before, the next 2.5 hours are vital to GAP. It's our chance to formally hear from you as our members around what are the priorities by disease area and by region of the world. And so the next 2.5 hours, 2.5 hours as you go to work, please, please, please stay very focused and engaged and know that what comes of these conversations absolutely will be fed back into our board as we make the strategic decisions for 2024 and as we seek funding from the partners that we had the conversations with, okay? So hopefully, again, everyone got some nourishment and you are ready to go to work. So our first breakout is by disease area. And the way that we have divided the groups is asthma, COPD, rare and or atopic diseases. And the reason we did this is just kind of looking at the registration, what made the most sense. And so, Victor, do you want to give us any, as far as logistics, directions on how we're going to break that out? Or are we just going to go to the three corners of the room? Okay. So three different areas of the room. What I'm going to ask is that if of these three areas, you identify primarily as an asthma advocate. That's going to be your disease state focus for today's discussion. If you'll raise your hand. Asthma advocates. Okay. So asthma advocates are going to go in this back corner here. Okay. If you're going to be identifying as a COPD advocate for the purpose of this exercise, raise your hand. COPD. I'm going to ask you guys to gather right here. Okay. And then if you identify in that atopic rare disease area, raise your hand. Okay, and you guys are going to go to this back corner. So we're going to do it as a triangle. And I think that our asthma group and our COPD group will likely be the largest. Now here's your instructions. Here's your instructions. You need to allocate your time accordingly over the next 40 minutes to these three topics, okay? So about 10 to 15 minutes per topic. Hold on, guys, sorry. Don't move yet. Shh. If we don't get instructions, it will make it very difficult, okay? So you have 40, 45 minutes, 15 minutes per topic that's listed here. What is your one priority message that you want to drive awareness? So there's going to be lots of thoughts, brainstorming, but then at some point in that time frame, you need to prioritize 1, 2, maybe 3 maximum to actually come out of your group, okay? And then move on to the one priority unmet need message in disease education. So if you had 1 or 2 education opportunities in your disease area in this next year, we're talking very near term, what would that be? Not pie in the sky, everything we ever wanted, because I know there's a lot, but 1 or 2 things that we would prioritize in the next year. And then thirdly, what is the one priority policy change in your disease area that you think should improve outcomes? So again, a brainstorming for maybe 8 to 10 minutes, and then a prioritization, and then move on to the next topic. There are moderators for each group, so tell me how that's breaking out. Who's doing what? I'm asthma, so the asthma group back in this corner is with me, yeah? Okay, Spila is with the atopic and rare disease group, and Victor is here with the COPD group. Okay, everybody go. You have 45 minutes. to speak. Elect someone to speak. 5 minutes, elect someone to summarize and speak. Okay, everybody. I know how quickly 5 minutes goes. I'm so sorry. I even had someone at my table set a timer so that we didn't exhaust time. So really great work. I know how quickly these sessions go, how many ideas are thrown out there, and how hard it is to whittle those ideas to one or two priorities. Okay, so we have 4 groups. Can I get everybody's attention, please? Sorry. We have 4 groups that are going to read out kind of their very bulleted messages of these 3 priorities, okay? I don't want to hear about everything you talked about. That's not what this is about. This is what did you prioritize in awareness, education, and policy, okay? So we are going to start with our rare disease group. No pressure. The mic's coming. And again, I'm going to put us on a timer. So 5 minutes for each group. We have to stick to that, okay? Ready?
Okay.
Take it away.
So I think I can see one of the biggest things we discussed as a group is driving the awareness campaigns around not just for as a whole, but and the patient education portion, the healthcare provider education part of it, and a lot of that discussion was around early intervention for the diagnosis process, and then the educational process for both the patient and the healthcare providers, especially in rural areas where there may not be as many specialists in certain communities in the rural areas, as well as early education for at the university level and even below for the healthcare providers and the physicians that treat certain specific rare diseases, and actually the requirement, because all these kind of tie in together, policy, the education, and the awareness drivers, but going to policy, the awareness campaign could potentially go for registries to help diagnose and treat rare disease patients. And this was a big bullet point, Tanya, was the gap, potentially creating a model for rare diseases in multiple languages and countries. I gotta read my writing. Oh, for an awareness toolkit for both the patient and the healthcare provider was a big discussion over here, and having that possibility.
Okay.
So, and oh, this is a big one. I remember this one from the last 2 years. Define rare. What does that mean? What does that look like? Because obviously it's
So
different.
is that the awareness key priority, is defining rare?
That was one of our big, this one was define what that means.
Okay, great.
So did I hit everything over here?
Venn diagram, almost like a picture, when you have some things that are common to rare conditions, and then kind of the decision thing that if you have a child that has recurrent infections and is in and out, find out whether the family has a history of somebody having that, because it could be PCD, it could be CF, could be alpha-1.
Gets you to that earlier diagnosis.
Earlier diagnosis. Yes. So creating for the gap to get together, create that toolkit, but then for people in their countries who are the ambassadors, who are the ones who really go to, we had an example in Brazil, educate people about what CF is to have that deck, that slide deck that is appropriate. What are the treatments that are approved in those countries? Because those resources may not be available around the world. So for the gap to get together and create that toolkit that explains these are the conditions, this is what you should be aware of, these rare conditions with these common issues, and then if it's that, here's the resource.
Excellent,
that you can go to.
And I'm not sure I clearly heard your policy priority. Could you reframe that for me? Policy, thinking about if you're talking to government, what's the policy priority?
Well, that ties back into education and awareness.
Okay, so funding for education and meaning HCP education. Okay, gotcha.
The whole shebang, yep.
Okay, perfect. Great job, rare disease team. Excellent. All right, next up we are going to our atopic disease team, and that's led by Spila. And are you going to be the spokesperson?
Yeah, I'm going to be the spokesperson. So I love how we actually have a lot in common with how we were thinking. So the first point of action We are happy that for the last few years we are talking about the impact on mental health so that it's not being not seen anymore, but still not enough. So we would go from here. Like one priority message for us would be the mental health burden of the diseases, a topic, all of them, with kind of understand us, like a message. Can you understand us? Like walk a mile in my shoes type of thing, yeah? So that would be the awareness thing. So the second one, we kind of, like we talked about today a lot, we have specific areas, specific diseases, specific type of problems. So we dared and made two messages. Like one for maybe Latin America, like our people said, and maybe Africa and all of that. Technology, like access to simple things as internet, simple things for those who have it, and like something that's really like a window to many things. Yeah, so that would be for those who don't have access to technology, that would be our first thing to do. And the other one would be to publicize more these diseases. Like this is a way of life, okay? So we're not just models and I don't know, actors and all of that, but some of us, many of us, a lot of us live with these diseases. Okay, the third thing, we were also talking about early stages, early action, so maybe like implementing something as simple, like we also talked before, but simple as a questionnaire in the early stages when, I don't know, a child is born or soon after, about some family history, like from the doctor or from someone who you meet from the healthcare professionals in that early stages, who can be prepared and look for the signs. I don't know, if I'm an atopic person, then there's a possibility my child will also be. So don't tell me about his skin is cleansing, you know, pay attention. So kind of that early, and that would be a simple one, I believe. You know, it's just a few questions to let you know, to be prepared, to see the signs, to maybe get that early diagnosis and change a life, save a life. That's it.
Great. And policy, how would you articulate that as like engaging government and policy on atopic disease? Did you guys have any discussion around that?
How would we get them to do that?
Yeah.
Well, the first, obviously, we have to go back to data again. Yeah. What are the numbers? How big of a thing it is? We were just talking about a doctor in Slovenia. He's a dermatologist, and he asked the system if he could have more time with his patients, atopic patients. And they said to him that there's not enough people, that they cannot do that.
So good burden and prevalence data.
And just how many people there actually are physically, because we don't have a number for Slovenia exactly, okay? For example.
Excellent. Great job. Atopic disease. Give them a round of applause.
Thank you. And the atopic diseases are on the rise, right? So.
Yeah. So now we're going to go to our COPD group. Victor?
Well, our COPD group is very proliferous, so we don't have one message. We have four messages per area.
Now they're really pressing the button. Four. Okay.
Yeah. So the first regarding awareness. So as COPD is the third cause of death. In every 20 seconds, one person dies. So the message will be, it can happen to you as a message. Then another message is COPD is the worst chronic disease in the world and the most costly disease for the healthcare system, families, and caregivers. That's the second message. Third message is anyone with COPD could have a good quality of life with the appropriate care and early detection. And the fourth message will be, as 1 in 5 patients have never smoked, and COPD is not a smoker disease, so the message is, what are your exposures? You minimize your exposures, and together we can make a difference for the people living with COPD. Everyone's agrees in there?
Great.
So,
very nice.
For the education and healthcare professional side, we have 4 more. So, wow. Well, the most prevalent disease, of course, we have more messages. So each patient is special, ask them why. That will be one key message on healthcare professional and education. Leveraging the caregivers to create referral networks and get more involvement of the caregivers into the patient care plan. Closer. And obligatory healthcare professional continued education as proposed by Mr. Land based on the unmet need of the lack of education for primary care as well. I mean, as well as, especially, yeah, as well as.
Where 80-90% of these patients reside, right? Primary care.
And then improve the two-way communication between patient and healthcare professionals. And which plays with another message, which is more collaboration with scientific societies that it will be involving also in this.
Okay.
And then, so for policy change, we have three, like one big message, which is access with several bullet points. So when access in COPD is access to diagnostic medication and reimbursement in the countries that they have that kind of healthcare system, to prevention, to active respiratory physiotherapy, and access to affordable COPD care as well, which is a concern in the low middle income countries, access to screening and early detection, access to medication of quality. There is also an unmet need brought by. Yeah. And access to a care that is fitting to each patient's need. That's one. Second one is inclusion of PERMs, or patient-reported outcomes, and value-based management, thank you. And the third message will be we need to do more investment in more inclusive research.
Okay, great job, COPD group. Although your definition of one is a little suspect, but I can't say too much because my asthma group, we did a little bit of the same dance. All right, guys, so from the asthma group, our priority message in driving awareness is the lack of knowledge of triggers, and talking about all the different triggers, whether that be environment, lack of access to medicines, lack of understanding about severity of disease. There's many, many different reasons and triggers that could be included in that priority message, but really focusing in not from the traditional sense of triggers being smoking, environmental, allergies, but broader triggers to poor control. So that's our priority awareness message. Our priority education for patients is you must have a personalized asthma management plan, and we talked about some of the components that would be built into that plan. So, but that is the one priority education initiative. What does a good asthma management plan contain, and why is it important? Our priority education message for healthcare professionals was targeted to primary care, because we feel like that's, again, where 80% of asthma patients reside and receive their care. And it is the same emphasis on the need for personalized asthma management plans, but slightly different components. Appropriate medication, a multidisciplinary team, realizing that asthma in most cases is chronic and controllable, the distinguishment between controller and relief medication, and we talked about the need for, of course, like inhaler technique, lung function testing on a routine basis, those sorts of things. And we talked about using validated tools like the AirQ or the ACT, and making sure that those are translated in order to assess control. So that is our primary care education priority. And then finally, our policy priority. So we had about 15 countries represented in our group. Only 3 countries have any type of national asthma plan in place. And so we decided that that would be our policy priority, is that every country must have a national asthma strategy or plan. And then we talked about some of the various components that would be included in that plan. Things like universal health care, access to school nurses and a multidisciplinary team, government subsidized medications, equal access to treatment, things like, again, diagnostic tools, annual spirometry, healthcare provider education, graduate medical education, research funding, so a lot of the same things we've heard here, patient engagement in clinical trials, PROs came up in our group too, But all of these kind of fall into a national asthma strategy, as well as environmental and tobacco policy as a portion of that. So that's our goal, is that in the next year, we will see at least 15 countries having national asthma action plans as a result of our efforts. So great job to my group. Did I miss anything? All right. So session 1 down. Now we're going to do a little bit of musical chairs and dancing before we move on to our next group. And we're going to break out by region of the world. We're going to have a Western European group. So if you consider yourself Western Europe, raise your hand. Yeah? Okay. That group is going to meet in this corner here at this table. If you consider yourself Eastern Europe, raise your hand. Okay. This will be this group over here, led by Spila. If you consider yourself North America, if you'll raise your hand with a primary North America focus, we'll be up in this corner. Ibero-America, who considers themselves that? Yeah. So that group, Spanish speakers, that's going to be a large group. So I think let's do them here. Okay. Asia Pacific, just a cut, 3, 4. Okay, you guys come to this table here. And then Africa and Middle East. Let's do Asia Pacific, Africa, Middle East together. Okay, so this table here for that group. Yeah? I can do whatever. No. You tell me where you want me to go. As you move to your groups. Okay.
You can do Africa, Middle East, and I will ask Christine to do.
Okay. We combine that group, so she's in the Asia Pacific Africa group.
You can match?
Yeah. Okay, so as you move to your groups, same situation. You have 3 tasks, 15 minutes per task. And what you're looking for is the biggest challenge. Everybody listening? The biggest challenge in your region of the world that you think we can actually address. Yeah, here. This is North America. That's the Latam. That's the Spanish speakers. This is North America. Okay, so I know everybody's moving. Hopefully you're finding your space. North America here. Western Europe there. Eastern Europe there. Latam here. And Asia Pacific here. Yes.
Oh, you do great.
Okay, everyone, we need to settle into our groups. Again, you've got 15 minutes per item on the screen.
15 minutes per item.
The biggest challenge in your region. Proposals to overcome that said challenge. So you need to agree on a challenge in the first 15 minutes, offer proposals to address that challenge in the second 15 minutes, and then thirdly, how can you collaborate? How can you work together to do that? Everybody got the concept?
Only one, she said.
Okay? So you might again spend some time thinking, brainstorming the challenges and prioritizing, and then move to how to address it and how to work together. Everybody ready?
Yes.
45 minutes, go. Okay, everybody, we need to be wrapping up. About 2-3 minutes. We'll come back for our reports out. Thank you. Go get on spirit. All right, everybody, it is time to report out. So this is going to get a little more challenging because we had a couple of more groups. So you have 3 minutes to communicate your biggest challenge, how you're going to overcome the said challenge, and the ways that you plan to collaborate across the region, okay? So we are going to start, not because it is my home nation, just because it's right here, with or my home region, North America, and Kristen is going to give us the report from this group.
Hello, everyone. Welcome to North America. My name is Kristen Willard. I'm going to report out on, first, our biggest challenge. So as you can see, we had several wonderful ideas. We focused, though, on the biggest challenge across these different conditions being awareness. So we used a colon so that we could have the opportunity to add things to this topic. One of those was social determinants of health. We know those are so crucial in impacting access to care, in impacting cost of care, all manner of things, actually. Access to Wi-Fi, everything under the sun, pretty much. Access and cost across the board for us was an issue. So the access and cost of care, of medicines, et cetera. And then the impact of disease is another one. The awareness about the impact of the disease, no matter which it would be of the above. For an example Stephanie gave us was that people often don't understand that these are chronic conditions that you will be facing for the rest of your life and managing the rest of your life. So awareness is the biggest challenge that we picked. We then moved on to how are we going to solve it, because we'd like to solve this as a team. What we'd like to do is partner across sectors. So the point was made in our group that we would want to involve organizations beyond health, right? Involve payers, find ways to present at their conferences to sort of be in their arena, and secure funding to, and then I'll go to the second part down here, to execute patient-driven quantitative and qualitative research. So that would include economic research. One of the examples that was given was looking at the cost offset for mandatory PR referrals. Dave gave us that example, and also conducting a survey about the topics that we just talked about on the first page to inform messaging as part of our sort of an awareness campaign. we have talked all day, we probably talked for many years about this, about how data really is the key to success. And so I think that's central to what we're talking about here, numbers and data getting attention. And then lastly, what I'll say is that we want to make sure that we're disseminating the results to the community, but really to all stakeholders, making sure all stakeholders are involved. Okay, lastly.
1 minute.
Here, oh, I'm ready. So opportunities to collaborate. We see us doing this through partnerships, right? Looking for funding together, ensuring that we plan and execute these research efforts as a partnering team, creating the surveys, implementing the surveys, doing the reporting, and doing that with all stakeholders involved. Thank you.
Excellent, North America. Love it. Great work. I hear some common themes emerging already. We're going to stay on that side of the pond and go to our LATAM team.
Thank you. Thank you so much. For the biggest, en español, no. For the biggest challenge, we said equity access, early diagnosis, and quality of medicine. Okay, this is the biggest challenge
and access to quality medicines.
For all of three. And our proposal is engagement with academy, scientific societies, and government in order to create awareness and everything. And our opportunity, or potential opportunity, one of them is a pre-electoral lab proposal. Pre-electoral, presidential lab proposal. Word they use the word they.
I love being aggressive. A presidential law, electoral. I love it. That's aggressive. I like it.
Yes,
Keep
because
going.
yeah, Word Day for create campaign awareness for every illness, corporate social responsibility. That's mean commitment with NGOs, and from maturity organization like a GAP, generating knowledge and providing support for countries and NGOs in progress to grow up. For example, she said about the Sareal, how can we support Ecuador, and Ecuador get a very good deal now with some medicine, because everybody support that team.
Yeah, so for those of you who don't know, Sareal is a conference that we actually have convened patient advocates in LATAM over the last 2 years. And out of that was birthed efforts in different countries in LATAM. One of them was in Ecuador, where just this week they advocated for coverage of essential medications and got it accepted for pH. So yes, yeah. Great job.
And the last one, generate data.
Okay, excellent. All right, great job, LATAM. Wonderful. All right, we're going to now move across the pond and come to Western Europe first. So Western Europe.
Mike, the mic.
Yeah. Oh, okay. Well, okay. Yes.
Okay, so from Western Europe, we first have like a list of 14 challenges that will trickle down into 5 solutions or proposed solutions. That will trickle down into 4 initiatives to tackle together.
I see a theme. 1 turning to 5, turning to 4, turning to... I gotcha. Go ahead.
Yeah.
All right.
So the challenges is there is no national plan for chronic respiratory diseases, the lack of access to novel treatments, to research, the perceived lack of initiative from some umbrella organizations or coalitions like the IRC, the challenges of climate change, the personal management plan in respiratory diseases that is not implemented in several countries, lack of government commitment, and healthcare professionals not referring to patient organizations, and the lack of collaboration between healthcare professionals and patient organizations, which is another side of the same coin. Then we have the lack of coordination between policymakers, institutions, and umbrellas with national patient organizations. The defunding of the healthcare system that we have lived, especially with COVID.
Yes.
And the many ideas that comes from meetings like this that they don't end up having like a
Pull through.
yes,
follow
like
up.
a functional,
Someone
like a
in
fruit.
charge
Yes.
and accountable, and yes, okay.
So some of the proposals to overcome all of these challenges is make awareness campaigns to break the stigma, make lung function tests in schools, allergy tests, having nurses in schools. There is a lot of emphasis in early diagnosis in children for respiratory diseases, having multidisciplinary groups in the primary care centers, and make healthcare professionals to prescribe patient organizations, and create more synergies in patient organizations working in health technology, AI, machine learning, etc. And then the 4 collaborative solutions that we found out that I think they're going to find very interesting is, first of all, making a unified campaign for early diagnosis in schools, which is the second one is a similar, very more like in-person, let's say, active solution is making a lung day in schools and public spaces to tackle early diagnosis and provide that education that is lacking with the younger ones, and join the EU initiative. This is number 3, join the EU initiative to create a tobacco-free Europe. Then number 4 is the push for more collaborative working environment with healthcare professionals from all the countries at the same time. So when the healthcare professionals meet at ERS and those kind of environments, there is a talk from many sides, let's say. And the last initiative that came out that I think you're going to find very interesting is a very practical solution, is impose a 1-cent tax in every cigarette pack that is sold in the EU, and that tax money to go
tax the hell out of them. I love it. All right.
and that money to go to a special fund dedicated for patient organizations.
Yeah, great. Okay, great job. Western Europe, appreciate them. We're going to go to Eastern Europe. I'm going to stick to your 3 minutes. Hard and fast. 3 minutes. Let's go.
Do you hear me? He says 14, that's okay. I mean, come on. No, we were actually really on the same page. Yeah, so our biggest challenge is early diagnosis. So not as both early as in young, and as in early if you are already an adult and you come to a doctor early. So you get it soon, not in as many years, okay? How do we challenge? How do we do that? So we were talking about creating guidelines in a collaboration with the doctors of the certain areas, of course. What do we mean? How do we overcome the challenge of getting an early diagnosis? So if we're talking about asthma, or maybe all of them need firstly a questionnaire, we mentioned it before. And then with asthma, with kids, that's all we have basically, but 6 years and above, we would make mandatory spirometry and reversibility test, okay? So with allergy and atopic dermatitis, with infant and preschool children, after the family history and questionnaire, we would make prick test or screening like mandatory, and also with adults and above. And how would we make all of this happen? With us collaborating together. So we would make guidelines together with doctors that when we would try to engage specialists that would want to help us and listen, and then we would make like an education for general practitioners, primary care practitioners and all of that. And then we actually had already ideas to how to do that in the next, how to make it happen. So, you know, make a round table, bring us all together, and then make an education like event for them in our own countries. So kind of like that. Yeah, that's it.
I love it. So it's that sort of train the trainer model where you guys are trained up and then you go out in your countries and do the same. Okay, excellent job. Give them a round of applause. All All right, last but not least, I'm going to represent Asia Pacific, Africa, Middle East. Really, we call this sort of a low to middle income country focus, excluding Australia from our region, given that they probably have different dynamics, okay? So our biggest challenge, we had a lot of challenges, but our biggest challenge, lack of access to medications. So in so many of these countries, even the very essential, thank you, medications that are on WHO's list are not covered. So that's our number one biggest challenge. The way that we're going to overcome that said challenge, we so that we could put together an effort, an initiative to ensure that that EML coverage is available with no out-of-pocket expense. Demand these governments to step up and to work alongside industry, and it is multiple layers here. So next is that we would craft an industry corporate social responsibility pricing statement at the global level, and then it could be adapted at the in-country level. That we would demand generic integrity, so quality medications, because there are a lot of imitation products that are less effective. That we could have some continued discussion around distribution networks. There was one that failed in this region a few years back, and so that conversation is sort of taking hold again. Supporting the WHO resolution and calling out this region specifically for its unique needs is another strategy that we offered. Government subsidized medicines, like calling out specifically policies around telehealth and digital health, and then taking the global guidelines and moving them to have a version that is tailored more to low to middle income countries. So taking that global guideline or quality standard and making sure that it's localized and has some adaptation based off of the limited resources of this region. Ways we can collaborate, model policy statements, consistent messaging, and just saying the same things and tailoring it to the unique needs of each nation. Responsible pricing statement, we already said. The WHO resolution, engaging member states, like everyone going to their member state saying, this resolution's coming forth, we need you to sign on. We demand that respiratory be prioritized. We talked about shared resources like money, data. Again, the wealthier nations, the more developed countries, we have a responsibility to support efforts in these regions. We've already talked about this, the globalization, regional and national, and having the different forums, just like we've talked about right now with LATAM and with Eastern Europe, moving that forward in Asia Pacific and Africa by GAP. And then, again, those are things that I've already mentioned. So data banks, key stakeholders, like if GAP had a central repository where you could go and say, these are the legislators, these are your policy members, these are your representatives, your ministers of health, your member state representatives at WHO, here's how to engage them, right? And give you very turnkey tools to do that. So that is our breakout. Did I miss anything, guys? We had a very broad region and discussion, but great work across the board. Okay, everybody, round of applause for the 2 breakouts. Is everyone getting to that breaking point, that's sufficiently tired and yet invigorated and don't know where to go next? That's me. So we're going to take a break. We're going to take about 10 minutes for a bio break and refreshment. And then we're going to join back in here at 10 till the hour for our closing session, okay? We will go a little bit over just because of how much, but I promise no more than 15 minutes, okay? Oh, no, okay, I looked wrong at my clock. I'm sorry, I gave you the wrong time. It's 3:23, okay? So be back at 3:40, and then I promise you we'll be done just shortly after 4 o'clock. Okay, 3:40. You'll have plenty of time this afternoon and this evening to continue to network. So dinner is at 8 p.m. We will meet just before then in the lobby of the hotel, yeah? And if anyone wants to hang out, maybe grab a drink around 7:30, please feel free to do so. There is that in the NH Milano. So just logistically, 8 p.m. dinner, come dressed in your country attire. It's going to be a lot of fun. We always enjoy this evening together, and it provides additional networking opportunities. So we've been through a lot today as we've talked about, number one, kind of how GAP has evolved, how we've grown, again, our strategic priorities and activities of 2023, the status of those things. We also talked about some really creative, innovative tools that we'll be using moving forward and that you can engage with. So GAP has already established the open door with all of those organizations and entities. And if you want to engage, if that's something that any of those strategies that you think are appropriate for you, come to us. We'll get you the access and the resources and all of that. The Storyvine platform, more to come on exactly how to engage and how to utilize that. So we've gone through all those innovative, creative ways to engage and support our communities in this next year. We also heard from our industry panel, which did just such a fantastic job of really answering some tough questions about how we best engage and why they support certain things at certain times, why they can't. But I encourage you to keep those lines of communication and conversations flowing, because what I have learned, and many of you know my background in that I spent years on the industry side before coming to the nonprofit side. And so mine is sort of the reverse of Allison. And, you know, I continue to learn things all the time, and especially in the last 2 or 3 years where the landscape has changed, where pharma has been, and industry has been much more open to patient engagement in all stages of the R&D process. And again, I just can't say enough thanks to our industry panel for that participation and great feedback. And then we went to lunch, had a delicious standing lunch. Hopefully it will hold you over since we have a late dinner. I'm probably gonna need a snack, just saying. I don't usually eat that late. But it was a great time of networking and really just catching up with friends from across the world that share the same passion in respiratory and atopic diseases. And then as we turned this afternoon, we put you to work. We did a lot of work at both the disease area level and at the regional level. We're gonna put together a report and feed this back out to you as a summary. And so I want you to check that, make sure that we're reflecting appropriately, that we're prioritizing, but that we're also action-oriented, that we're taking what we heard and turning it into specific actions to hold GAP accountable and to hold you as our members accountable and how we're gonna collaborate and work together. And you know, I started by asking the question, oops, wrong direction. How are you? Honest answers only. And I alluded to the fact that this year has been hard for many reasons, personally and professionally in my life. I've shared with a few, I've been battling a little bit of a health issue. I have parents and in-laws who are battling health issues. And to be honest, there's been days where I've been somewhere between quitting and winning. And I've tried to keep that in perspective, that we all have days like that. There are days when, honestly, as advocates, I know you want to throw up your hands, walk away, and do something much easier with probably more pay, right? Anybody can relate to that? Yeah. And yet there's also those days, like today for me, where I feel like I could do this every day, all day, until I'm in the grave at hopefully 90 or 100 years old. And so wherever you are today, I want you to continue to check in and to think about how are you honestly. And don't be afraid to reach out on those days when you really want to quit. That's what we're here for. We're here to say, don't quit, you're doing a great job, let's find a way to keep it moving forward. We lost one of our advocates this year in COPD, and it's very sobering when that happens. But it's a wake-up call, too, to live every day to its fullest and to embrace the opportunities that present themselves in our personal and professional lives. So reach out to us, allow us to be there to support you and to keep you in that winning side rather than in the quitting side of that equation. We know it's hard. I know that you're doing so much with so little on the daily basis and stretched thinly. And so please let us be that level of support. So if I reach out to you on WhatsApp or in an email and say, how are you? Honest answer only. I want you to tell me, please. If the team does that, please respond. If the board does that, please respond. And then the second question I'm going to ask is, how can we best support you now? Right? Because what you think of today, what we've discussed today, may not be the same thing that arises at the end of the year or in Q1, Q2. So we'll keep checking in on those two things. How are you doing, honestly? Don't say fine. I don't believe that answer. It's often a lie. And then, how can we best support you? Those are the two things that we commit to continuing to come back to you throughout this next year. And so the final thing that I want to do is to leave you with a bit of inspiration and challenge. GAP has had a very unique opportunity to engage two stellar, amazing advocates in this space for the coming year. And so the first is an IndyCar 22-year-old fresh face named James Rowe. James races for Andretti IndyCar, that team, Mario Andretti, who many of you know. He lives with severe asthma and absolutely does not allow it to limit his ability to drive 200 miles an hour down a track in the middle of crazy places and succeed. And he's a rising star in the IndyCar space. And he just went public with his affiliation with GAP, the recognition on his car. He's willing to do PR. He's willing to do all of this. Again, no cost to you. We've engaged him. We've got the relationship. And again, he's originally from Ireland. He also lives with other type 2 diseases, so he's not solely living with asthma. And so again, maybe an opportunity for you to think about how you engage that type of celebrity in your community. And then the second is another sports figure that I am very excited to actually bring to the stage and to join us, and it's Jake Cohn. And Jake is a free skier. And I was not familiar with this because I am not an extreme sportist. I know you probably find that hard to believe, but I'm not going down slopes at 100 miles an hour. Not my chosen fun activity, but it is his. And Jake's going to share a little bit with you about his experience of living with severe asthma. He's going to inspire you to really not focus on your limits or your labels, as we often do. We often get stuck in those limitations rather than on the opportunities. And he also, I think, has a very interesting story that's still in progress when it comes to his lung health. So he'll share this with you from infancy all the way through to today and where he's headed in the future. Lung health has been a very central part of his life and his journey. And so with that, let's welcome Jake to the stage, and you guys enjoy this closing session.
Thank you. This is down, right? Okay. Hello. So, I'm here today to talk about something that has been part of me my whole life, asthma. And asthma sucks. Yeah. You're bad at the one thing you need to be good at to survive, breathing. So this is my reality. So, as you can tell, no, don't clap for that. As you can tell, I've got really bad lungs. I have chronic asthma, and unfortunately, it's getting worse as I get older. My FEV1 is about 25%, and I've yet to have an FEV1 over 50% in the last 10 years. My SATs, they get extremely low. They drop when I do things like walking or talking. They get to numbers that would shock most people in this room. And my attacks, they're getting more severe. Frequently, I end up in the emergency room. But you have to be tough. You have to be tough to survive as an infant being intubated at birth. You have to be tough to learn how to walk connected to oxygen with a cannula taped to your face. You have to be tough to have spent many of your first birthdays in the hospital. And you have to be tough to be labeled as the sick kid going through school. But it's my toughness and my stubbornness that has landed me on this stage here. So, I want to take you guys into an asthma attack like you just saw. Asthma attacks so severe that I'll have to go to the hospital. And they'll start where I'll catch a bug. Maybe I'll get something from traveling. Maybe it was the flu that was going around the dorms when I was in university. And that will go right to my chest. I'll have this chest infection, and I'll try to fight it. I'll try to take an antibiotic. I usually take azithromycin, but my body is now so tolerant to that my doctors have suggested I take Levaquin. However, there's a side effect of Achilles tendon rupturing, and that sounds horrible for anybody, but in my profession, would be extra bad. I'll also take a high dose of steroids, but it won't do anything for my attack. I'll start to cough. I'll cough up colorful mucus. I'll constantly be trying to clear my lungs. I'll sometimes hit my chest like a gorilla in the jungle, trying to loosen up anything, but I keep coughing. And each time I cough, I think that my attack may be over. I mean, the definition of insanity is doing the same thing over and over, expecting different results. And I'm going crazy during one of these asthma attacks. I cough so hard, my nose starts to bleed. I continue to cough, my SATs drop. Each cough is getting more violent, more painful than the last. It's like the Penrose steps of coughing, up or down, around and around, never ending. I cough so hard, I throw up, and then I dry heave. I can't stop coughing. And I know at this time, I have to go to the hospital. But like I said, I'm stubborn. So instead of calling an ambulance, I'll drive to the hospital. I'll be in the car, gripping the steering wheel at 10 and 2, head between my arms, coughing uncontrollably. And as I'm driving there, I'll have a memory. I'll remember being a kid on a road trip in the back seat of our car. Our car had power windows, and I'm sitting in the back playing with the automatic window button. Click, 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 click. My dad has locked the back windows, but I'm still playing with the switch. Up, down, up, down. My dad is annoyed. He turns around, he looks at me, and he says, "Jake, did you know each switch only has a certain amount of switches in them before it breaks?" Well, I think of this when I'm coughing uncontrollably. Do my lungs only have a certain amount of coughs in them before they stop working? And what is that number? Well, you have to be stubborn to survive an attack like that. You have to be stubborn to live with low lung function. And like millions of other asthmatics, I desire a life free of asthma symptoms. And after what I just described, you really wouldn't think I could do anything, let alone go skiing. But it's because of the work that you do that I'm also able to do this. Yes. Thank you. Yeah, appropriate clapping. I've been a skier since I dedicated myself to the sport in grade 7. And my life as a skier is pretty amazing. I get to travel the world and play in the mountains. I've skied on 5 of the 7 continents, some of the world's most amazing mountain ranges. I mean, just think about how cool it is that with skis on your feet, you can descend thousands of meters in a matter of minutes. I want you guys to imagine a mountain in the summertime. Think of the topography. Think of, you have trees, logs, cliffs, boulders, valleys. Think about how long it takes you to descend that mountain. But if you just add some frozen water, like magic, you have a white canvas covering all or most of those obstacles. I look at it and think, what logs can I ride on? What cliffs can I jump off of? Or what trees can I accidentally hit like you just saw? I'm at the top of my line. I click into my skis. I push off. I drop in, fresh snow ahead of me. I build speed. I lean my weight to the right, to the left. Snow over my head, engulfing me, hitting me in the face, bouncing off my goggles. It's like I'm Neo in the Matrix, dodging snow bullets. It's probably as close to flying as I'll ever get. With skiing, my life has been great. Being able to travel the world with my best friends, compete at an elite level, the thrill of winning contests, and the commitment it takes to make a ski movie. But I still can't breathe. So, I'm gonna do an exercise with everyone. Let's all take a big breath in. Now breathe out. Okay, let's do that one more time. Now I want everyone to grab their straw that was placed on the table. They're clean. Okay, now put the straw in your mouth and take your finger and plug the other end. Now just move your finger a tiny bit out of the way so only a small bit of air can get through. Now breathe through that straw. If you find yourself cheating, plug your nose. Now you're breathing like me. I don't know how many of you think about how many breaths we take in a day, but it's a whole lot. We take about 25,000 breaths a day. Each of these breaths keeping us alive. But for me, I don't just think about breathing. I obsess about breathing. That's because for me, each breath is a struggle. For me, it feels as if this straw is there 24/7. When I wake up, the straw is there. When I'm exercising, the straw is there. When I go to sleep, the straw is there. For me, each of the thousands of breaths I take a day is compromised, making me feel like I'm suffocating or drowning, like a fish out of water, gasping. And because my lungs don't work and there's an improper gas exchange, my heart has to work harder. I have headaches. It's a negative feedback loop that makes me feel weaker. Well, my body has learned to adapt somewhat to low oxygen levels. And my doctors are monitoring my heart closely, and so far it's putting up with this quite well. However, unfortunately, during one of my last ECGs, they did find early signs of pulmonary hypertension, which is what they're worried about. They suggest that I exercise now with oxygen, and I'm much better at short bursts of energy compared to aerobic exercising like cycling. But if I exert myself with oxygen, I could have a higher baseline. So, I get excited about the future of respiratory health. I'm excited about new therapies. It's a big change from when I was a little kid growing up. My family doctor would just prescribe me with a high dose of steroids whenever I got sick. I mean, I grew up in a tiny town in Colorado. My house was at 3,000 meters. My family, we had the first oximeter in our county. And the doctors would only react to my asthma symptom. There was no preventative care. Asthma is such a diverse disease. There's not a one-size-fits-all approach. For me, I have low eosinophils. My lungs look like I have COPD. with not very much lung tissue. For me, asthma is from birth to death. But I think it's important to look at lifestyle from a preventative point of view. I was in denial about my asthma. Many patients are. But if I had maybe listened to my doctor and made some lifestyle changes, I may have higher lung function today. There's also a confidence aspect. Many patients are embarrassed to take their medication in public. I was embarrassed to use my inhaler in front of my peers. And the role you guys play with your patients is crucial in building trust. I'm lucky that I can call or text my doctor. While I was in Japan in the hospital, I was FaceTiming him while on the other line with a translator, and he helped me get out of that hospital earlier. Now, I know this isn't realistic with all of your patients, but building trust with them is, and it is important. I never leave my doctor's office feeling like I should have asked something or why didn't I say this. Building trust with your patients will not only help them survive, but it will help them thrive. So, despite my damaged lungs, I have persevered, and I haven't let my condition get the best of me. I may always be breathing through this straw, and someday I'll probably need supplemental oxygen to go skiing. And at that time, I maybe won't be jumping off cliffs. But it's the work that you do that has allowed me to live a fulfilling life and be a role model for other asthmatics to show them that with proper care, they can also have a fulfilling life. So just remember that the work you do with your patients is so important. Thank you.
Thank you, Jake. Again, as a mother and a grandmother, every time I watch that video, I'm like, oh, here he goes. I've seen it 100 times, and it still makes me nervous. But so inspirational, and again, thank you for sharing your journey, and certainly, again, the life course, right? It's something that you're still in the midst of. You're very honest and raw about that. Any questions for Jake as we kind of conclude his time of sharing and testimony?
I'm going to go to dinner with you guys, so you can also ask me there if you're.
I'll be around this evening. Yeah, and again, Jake is very open to working with each of our organizations, with GAP as a collective. So if you want to talk with him, want to engage with him, certainly feel free to do so. Yes?
You. Of course. So
medical regimen was the question. What is his medical regimen?
Yeah, in terms of drugs, I'm on Advair, and on average, probably do a neb a day. I've kind of been on a laundry list of drugs, but nothing has really worked. I take steroids when I get sick, or an antibiotic when I get sick, but like I said, I'm kind of more tolerant to those. But in terms of I really try to avoid getting sick. Yeah. I've tried a biologic. I've tried some things and it didn't work, but I know there are new ones in the pipeline or that are happening, so always down for new treatments.
And I will say, when I first heard Jake's story, we were at a corporate event together, and I immediately said, oh my God, he's undermanaged, right? And so we go to dinner. You don't mind me telling the story, right? Yeah. We go to dinner with literally the world experts in severe asthma, and we're having this conversation, and all the physicians at the table are saying, dude, you're undermanaged. Dude, you're undermanaged. And so we start asking questions about where he's managed and how his. Do you mind telling them where you actually get your care?
Fortunately enough, I'm from Colorado, and I've been going to National Jewish since I was a baby.
Yeah.
So
so for you guys who are not in the U.S. And may not realize, National Jewish in Denver is the premier respiratory hospital and health system in the country. Yeah. And so, it's one of those situations where sometimes, and I did this to Jake in full disclosure, I made the assumption that he was probably not getting that level of care and the needed support. And at dinner that night, it was like a light bulb, because again, great friends of ours who are experts in the field were like, wow, you're at you're at the best of the best, and you still are having some of these challenges, and we haven't quite figured out your disease. So I'll go to Lauren next, and then we'll go here.
Well, that was one of my questions. Where are you going to National Jewish? But this on? Okay. Oh, sorry. Thank you for telling your story, for one thing, and also I have a laundry list of parallels with you. But it was also fascinating to me and wanting to know because cold air often exacerbates, symptoms. So I had a question around how you can control that when you're high altitude.
That is a good question. I know the lungs like warm, moist air. It's never really been a trigger for me, and maybe it's because I grew up at altitude in a dry place where it snows a lot. But I've never had that really trigger me. So
okay.
But I know some people are triggered by that.
Yeah. Thanks, Dr. Mustafa.
I'm standing up.
Thank you very much for sharing this such a fascinating story. Not a story, it's a factual.
Thank you.
And that's what you have shared with. Being a respiratory physician, I'm a pediatrician anyway, but I'm very much dealing with all these cases. I'm a pulmonologist, pediatric pulmonologist. So my query basically is only one. Although this institute where you have been treated is the very best one, as Tonya is telling us, but my concern is that asthma as per se usually does not cause that much lung damage as you are sharing your stats and all that. So my question would be, do you have some other associated diagnosis with it or not?
Good question. And part of my story I didn't share, which in one of the last talks I have my baby videos and that stuff. I was born 5 weeks early, and growing up at altitude and not managing attacks really scarred my lungs. I really don't have like half my lung or lung tissue that works, and that is really what is the issue here.
Yeah.
That I can't, that's why my stats are so low, and they've looked at other things. But
Yeah, and so to that point, we were talking earlier in the day about the advancements like in RSV, and that now in utero, mothers can actually be vaccinated against RSV for their infants to protect them and to progress their lung health even in utero. And it's why GAP is committed to that space, right, of not only chronic respiratory diseases, but also these infectious diseases and the way that they compromise lung health over one's life. Healthy lungs for life is really the motto. And, that's some of the work we'll continue to do with Jake, because I think that his story is not over at all, right? I think, and even since we first met back in the summer and started talking, I've had conversations with providers, and I'm like, maybe that's what it is. Maybe that's what it is. Maybe there is more to this story than just that asthma diagnosis, right? And again, the lung injury as a child and the way that has progressed his condition.
I haven't given up
over
looking.
time.
I'm all ears for.
Yeah,
for
and then even the
therapies
pulmonary hypertension conversation that you just mentioned in passing, like very casually, you said, "Oh, they're working me up for pulmonary hypertension."
Well,
right?
I can't live at altitude, unfortunately, even though I was born there. I have to be at sea level. When I'm home, I sleep with oxygen, and so I can't live there long term.
Yeah. So again, To Be Continued. We're going to follow Jake and his story and share more with you. And again, I would encourage you tonight to engage and to learn more about his journey and how his passion for this space can support you in your work and if not, again, more so, I hope that this reinforces that we still have work to do, right? That our job is far from over, because there's individuals just like Jake who had the same testimony, who had the same journeys, the same struggles. Many of you are living with these conditions. Most of us have someone in our families who are living with these conditions, and who, again, it depends on our activity collectively to change the space. So thank you, Jake.
Yeah, don't be shy.
Yeah.
You can talk to me.
All right. Well, again, we have had a very full day. I cannot say thank you enough to, again, the team, the amazing GAP team, board of directors, staff, everybody who made this happen. Great job. Our AV team who kept us plugged in online. Our sponsors, again, without their support, we would not be here. We could not have these kinds of events and opportunities to convene, to network, to advance care, to align on our strategic objectives for the coming year. And this isn't an end. As we finish up the day and head to our afternoon and dinner, this is the starting point. This is not the finish line. It is yet another milestone in our journey together to ensure that together we can achieve that vision and mission of a world where people live better with atopic and airways diseases. Finally, thank you to you. I know it's a long day. I know it's been warm at times and all the activity. I know we've not given you a lot of downtime, and you've stayed engaged and you've stayed present. And what a joy it is to be here in Milan with each of you and to just share this moment. I know we're going to look back and say, remember that meeting where we had this talk and agreed to do this and that? In another 5 or 10 years, who's to say the impact that GAP and our community will have on this space and the landscape? So thank you, thank you, thank you. Have a wonderful afternoon. See you tonight. Photo. I almost forgot. Thank you, Victor. Everyone to the front for a photo, please. Yes, I'm sorry, Gundula. The other thing I'll mention, Gundula has her 15-20-minute film that was aired last night. So for anyone who wants to stay an extra 15-20 minutes, you are free. We'll watch it on the movie screen, okay? So for anybody who wants to stay after the photo.